and we have 9 doctors here. So we'll discuss. So this is the first question. Second trimester pregnancy, anxious, shortness of breath, disturbing husband from sleep, have history of anxiety when as university student diagnosis. Like usually in our classes today we are having some new doctors. So like when we discuss in these recalls, I'm just asking your opinion. Okay, first I'm asking your opinion, then we will discuss together everything. Okay, so what do you think for this question, doctors? Tell me what is your opinion? What about other doctors? Just give me your opinion. There's no one here to judge. Yeah, there's no one here to judge. We are here to learn something, right? So because of that, you have to actively participate. Okay, we got trees and we got A's. Okay, good. So first of all, let's discuss about this anxiety disorder. So what are those anxiety disorder types? Anxiety disorder types. Okay, let's discuss about anxiety disorder types. So, additional signs and symptoms for anxiety disorders based on type and described below. Here, generalized anxiety disorder, we have social anxiety disorder, we have panic disorder, we have phobias, right? We have separation anxiety, and we have substance or medication induced anxiety. Right, doctors? Okay, yeah. Okay, so we'll discuss. First of all, what is a panic attack? We're just discussing some theory behind it, okay? What is a panic attack? What is a panic attack? Tell me about the panic attack. Because these are very important, okay? Very important. You need to know the theory behind it. Otherwise, it's very hard because they are not repeating the same question in the exam. Just they are repeating the topic, right? Mm-hmm. Okay, acute feeling of impending doom. Yeah. What about other doctors? So, what is a panic attack? Okay, panic attacks are defined as a discrete period of intense fear or discomfort, or symptoms of panic attack may be initially suggest an acute medical condition like heart attack, stroke, like this. Okay. So, to diagnose panic attack, four or more following need to have developed abruptly and reached a peak within 10 minutes. Please remember the diagnostic criteria, okay? Because of that, I have added this one. So, what are the things that you can see in? What are the symptoms that you can see in panic attack? We have palpitations, pounding heart or accelerated heart rate, sweating, trembling or shaking, sensation of shortness of breath or smothering, feeling of shocking, chest pain or discomfort, nausea or abdominal distress, feeling dizzy, unsteady, lightheaded or faint, derealization, fear of losing control or going to crazy, fear of dying, paresthesia, chills or hot flushes. At least there should be a four or at least four or more of symptoms, and they are coming peak within 10 minutes. Okay. Yeah. So remember about this panic attack. Now tell me what is a panic disorder, doctor? Panic disorder. Tell me what is a panic disorder. Tell me what is a panic disorder. Yes. Okay, 1 minute. Yeah. Actually, the panic disorder is recurrent unexpected panic attacks with persistent worrying about future attacks, right? They are always worrying about future attacks, right? And may occur during the sleep as well, right? Panic disorder. Okay, now tell me what is social anxiety disorder? Social anxiety disorder. Because you should know, you have to differentiate each of these. So tell me, what is social anxiety disorder? It is a marked fear of social performance situations where the presence persons may be judged, like public speaking, meeting people, eating in public, like that. So what is generalized anxiety disorder? What is generalized anxiety disorder or GAD? Tell me. It's excessive worrying about many areas of life for more than 6 months, associated with fatigue, irritability, poor concentration, like sleep disturbance. They are constantly worried about their life, right? Yeah. Then what is a specific phobia? Specific phobia, doctors? A specific phobia means fear of specific objects or situations such as animals, height, blood, flying, like that. Okay, we have a clear specific trigger, right? Then what is agoraphobia? Agoraphobia has asked in, I think, February or November. Tell me what is agoraphobia? Agoraphobia is fear of situations where escape is difficult, right? Like crowded area, public transport, open spaces, right? Yes, yeah, escape is difficult. Good, right? So these people avoid public places or traveling alone, right? These are like a key points that you can see in the step, right? Then what is pregnancy related anxiety? It is anxiety related to pregnancy, fetal health, labor, or miscarriage, right? Okay. Yeah, we have discussed. Okay, we'll do some questions. Then we will go back to our actual question because I need you to differentiate about these. What type of panic attack? What type of anxiety disorder is that? Because that is the theory you need in your exam, right? You need to differentiate each of them. Okay, tell me, 28-year-old woman present to the generalized practice in clinic. So concerned about feeling anxious. She reports experiencing increased worry and restlessness over the past 2 weeks. Uh, coinciding with an upcoming job interview for position she really wants. She described difficulty falling asleep some nights due to thoughts of about the interview, but is able to sleep through the night once asleep. She continued perform well and her current job as a and maintain a social commitment. Through find herself occasionally distracted by thoughts of interview, and she has no significant medical history and take no regular medications. On examination, she appears well with vital signs within normal limits, and she is alert, oriented, and engaged appropriately in conversion. There's no signs of psychomotor agitation or retardation. Which one of the following is most likely to diagnosis? Tell me, doctors, what do you think? Give me your opinion in the chat box because you need to differentiate these. Okay. Mm-hmm. Okay, here, yeah. A normal anxiety, right? So, why this case presents scenario where it's crucial to differentiate between normal anxiety and anxiety disorders. Why? The patient's symptoms are most consistent with normal anxiety, which is sorry adaptive response to stressful events or situations. So, normal anxiety is characteristic by worrying and physical symptoms that are proportionate to the stressor, time limited, and do not significantly impair daily functioning. In this case, the patient's anxiety is directly related to the upcoming job interview, which is common source of stress, and her symptoms have been present for only 2 weeks. Coincided with the anticipation of the interview, while she experienced some sleep disturbance and occasional distractions. Right? She continues to perform well at her current job and maintaining her social commitment, indicating that her daily function is not significantly impaired. Right? Okay. This question explain everything about GAD, panic disorders, and social anxiety disorders and other adjustment disorders with anxiety. So you can give it a read later because I have already explained about it, right? So remember, in conclusion, the time limited nature of symptoms, their direct relationship to a specific stressor, and the absence of significant functional impairment all points to normal anxiety is most appropriate diagnosis. It's very important for clinician to recognize and validate normal anxiety from other anxiety disorders, right? Yeah. Here, anxiety disorders are characteristic by excessive, persistent worry that interferes with daily activities and quality of life. Okay, another question. 24-year, because we got some questions about panic attacks in February, right? No, November, I think November, because I have attached these questions from that. A 24-year-old final year university student attend her GP requesting medication to help with her exam nervous. She's able to function without issue throughout the day, sleep 7 hours a night, eat well, exercise 3 times a week. She attend meditation classes and has tried positive self-talking, but this is not prevent her anxiety about exam, which has been ongoing for her thoughts her whole university studies. In practical exam, she says freezes, get a dry mouth, palpitations and mind blank, and feels she will fail. The experience she marks fear for being negatively evaluated by examiners and avoid volunteering for practice demonstration in class. She has a previously failed formative exams. Her upcoming exam is in 6 months in time. Which one of the following is most appropriate first line treatment? And tell me, okay, you can tell me. I know everyone can tell me the treatment. Tell me for first of all diagnose this. First of all, diagnose this. What is this, doctors? What do you think? What type of stress disorder is this? Give me your opinion. What about other doctors? Dr. Abab, do you remember we have discussed this question in February as well? Okay. What about other doctors? Okay, let's see here. Mhm. Okay, doctor. That's the I know. I'll explain in the next question as well. This student is presenting with performance only social anxiety disorder, previously termed performance anxiety. So she experienced marked fear and anxiety, specifically performance situations like practical exams, right? Where she may be scrutinized by others, leading to physical symptoms including dry mouth, palpitations, and cognitive symptoms such as mind blanking. These symptoms are situationally bound to the performance context, and she functions well with area of her life. The fear is persistent. She has previously failed exam due to these symptoms and cause significant distress fulfilling diagnostic criteria of social anxiety disorder or performance only subtype, right? So the first line therapy is what? CBT, right? CBT. Okay, I'll give her another question. Okay, this is the question. A 19-year-old old at the end of her first year university studies, attend her GP requesting help with exam nerves. During examination, most significant OSCEs, she reports feeling faint and diaphoretic. She also feels nauseated and experience palpitations and feeling short of breath. She has sometimes felt numbness in her fingers, and she has never previously been a issue for this patient, but has happened with increasing frequency over the last 6 months since received the poor examination mark in earlier this year. She has avoided two midterm assessment since due to worry about these symptoms reoccurring. She reports that her overall mood is positive, which is congruent with her affect in the consultation, and that she is able to function well throughout the day and sleep comfortably. 7 hours a night. She eats well and exercise 3 times a week. She has attended medication class and has tried positive self-talking, but does not feel that this assisted her. The find that she is preoccupied with thinking about these panic symptoms for majority of the day in the led up to her exam. Which one of the following is most consistent with her symptoms? What do you think, doctors? What about the doctors? Yeah, Dr. Abab and Dr. Kumari, we have done this question previously, right? Okay, here I'm going to explain. Here, what we can see, the symptoms of this patient experiencing are consistent with specific phobia disorder, right? In this case, the assessment phobia, right? One good. Yeah, sorry. Assessment phobia. The attacks have become recurrent, however, occur in predictable triggering situations surrounding assessment. The patient has experienced functional impairment, now being unable to attend assessment. However, this impairment only occurs in relation to upcoming exams. DSM-5 criteria for specific phobias include this presence of unreasonable excessive fear, avoidance of or exam distress, significant impact of life activities, lasting greater than 6 months and cannot be due to an underlying disorder. Right. So here also they have explained other disorders as well. You can have a look. Okay, you can have a look later. Yeah, let's go back to our question. Okay, here. This is the question. Second trimester pregnancy, anxious shortness of disturb, husband from sleep. Okay, she is having some kind of anxiety, right? Some kind of anxiety, anxious, shortness of breath, disturbing her husband from sleep, right? So because of that, husband also get disturbed by her anxiety or shortness of breath. These symptoms, right? This anxiousness. So have history of anxiety when a university student. So diagnosis. Okay, most of doctors went with recurrent of anxiety disorder, and some doctors have gone with pregnancy-induced anxiety. Here, doctor, the key point in this question is the history of anxiety when as a university student. Okay, this patient have the history of what history of anxiety as a university student, and now she's in another anxious period like a pregnancy, and these symptoms can be reoccur. That is the most possible explanation that we can see in here because of the history of this patient's anxiety during the university period. Here, the stem clearly state that she already had anxiety when she was a university student. Now, during pregnancy, she is experiencing anxiety symptoms again. This suggests return of previous anxiety condition, not a new disorder, right? If there's a previous history, we can think about recurrence, right? Not a new diagnosis because already having a history of anxiety disorder, right? Right, doctors? Here, if it is pregnancy induced anxiety, they are giving like patient is always like thinking about the fetus, and they are not mentioning like a recurrent anxiety, right? They're just giving they are like a new sets of symptoms, right? If it is pregnancy induced, right? Because of the pregnancy, but here the patient is already having the history of anxiety when at the university, right? So because of that point only, we can go with recurrence of anxiety disorder. But here, so I can mark here recurrence of anxiety disorder. But in the exam, they can give like more details, right? More details because here they are just giving some kind of anxiety disorder, right? They have not mentioned which kind of anxiety disorder. But in the exam, they can mention about some, as example, panic attacks during their university time. So patient is having recurrent panic attacks, and they can tell, and patient is now pregnant, and patient is always having like always having fear of having a recurrent panic in like those kind of stem they are giving, then you can think about panic disorder, right? It's depend on the situation, doctor. That's why during the exam week, this is my exam week file. Okay, I have attached everything for my exam week, but not very quickly. We have discussed because all doctors were very exam oriented. I have just explained like the yellow part, specific part. Only not like this, okay? During the exam week, because the time is another time is goal during the exam week, right? Yeah. So in the exam they can give more details. That is why we have to go through each anxiety topics, because we don't know in the exam they can change the step, right? This is just a recall, very small part, right? We actually don't know which type of anxiety disorder this patient is having, right? It can be specific phobia for assessment, right? Like that. Because of that, always keep in mind like the key points, right? Key points. And I have attached some key points as well here. Like sudden attacks without trigger can be panic attack, repeated attacks, and worrying about getting again the panic attacks or panic disorder, fear of public faces, agoraphobia, fear of being judged, social anxiety, fear of specific objects, specific phobias, constant worry, general anxiety disorder, like that. Always keep in your mind about what are the possible outcomes, especially during the exam week, because your exam is coming, right? The April doctors, and they have AMC has proved us that they have changed the standards again, right? Because of that, you have to be more conscious about. Yeah, thank you, doctors. You have to more conscious about the March exam, right? Because we don't know, like they can be increase the standard like more than this March exam. But February exam was so good, and like we never expect that much of easy exam from February, right? Usually, like the according to AMC myth, right? They are like having they are saying like other doctors saying usually the February exam and June exam are harder, right? Why like they are increasing the standard, because they are like new 6 months, right? February to May, then next new 6 months started from June, right? That okay, but we can't predict actually, right? We can't predict actually. We have to prepare, right? Because in the this time February exam was a very good exam, right? Okay, yeah. So we'll move to the next question. I'm taking this much time because this is our recall class, like how we should approach recalls, right? Otherwise, you can't understand during the exam week. Yeah, I think we have discussed this one. Okay, next question. Sorry. So, a picture of lower limb. This is February recall, doctor. A picture of lower limb laceration with swelling. History of motor vehicle accident. Peripheral pulse not palpable. X-ray done shows tibial and fibula. What next? Reduction, wound debridement, tetanus prophylaxis, fasciotomy. What do you think, doctors? Mm-hmm. Okay, now tell me why reduction, doctors. What is the reason behind it? Okay. Mm-hmm. Good doctor. Yeah, good doctor Abab and Rehab. Rehab. Now, what about other doctors? Because you need to know the theory behind it. Mm-hmm. Yes, good, Dr. Kumari. Okay, we'll discuss from some questions. Okay, you have to answer, otherwise you are not understand this properly, right? I will explain after these questions like proper algorithm, but before you have to understand yourself by doing mistakes, right? Okay, yeah. Okay, here a 28-year-old man. I'm not showing the answers because they have already marked this one, this e-medicine. So now tell me. My God, doctors, just 1 minute, okay? Just give me 1 minute. Yeah, because one doctor has like want to join the this class now and asking for the stay. Yeah, just 1 minute. Okay. Okay, doctor. So let's discuss. 28-year-old man present to the emergency department after motorbike accident. He reports severe pain in his right lower leg, uh, which he is unable to move. The injury occurred 1 hour ago. He has no significant medical history and does not take any regular medications. He works as a mechanic and does not smoke. On examination, he appeared distressed. His pulse rate is 110. BP 130 by 80, respiratory rate is 18, SpO2 99 on room air, and the temperature is 36.9. There is a 6 centimeter wound over the anterior aspect of the right tibia with exposed bone activity bleeding. The foot is cool, but pulses are palpable. Sensation is reduced over the dorsum of the foot. X-ray confirm comminuted mid-shaft tibial fracture with displacement. Okay, they are asking which one of the following is most important initial step in management. I'm giving options: IV antibiotics, reduction, then wound debridement. What do you think? These are the options. You can select from these three. Tell me, doctors. Okay, 1 minute. Sorry. Tell me, this is the answers. Okay. So you have IV antibiotic. Okay. Then you have what? You have reduction of the fracture, and you have wound debridement. Tell me, what do you think? What should be the answer? Mm-hmm. Why IV antibiotic here, doctors? Why? Okay, doctor. Uh, I'm repeating. Mm-hmm. Okay, here. Yeah, these are the options. Okay, this is the question. Here, the answer is IV antibiotics. So why? why? Why we should give IV antibiotics here? Here, the answer is administer intravenous antibiotic is the most important initial step in the management of an open fracture. Early administration of broad spectrum antibiotics significantly reduce the risk of deep infection, right? Mm-hmm. Okay. Yeah, good. Infection, which is major complication of open fracture. Antibiotic prophylaxis should be given as soon as possible for most open fracture. Here, most open fracture initial. Okay, some exceptions include facial fractures not requiring surgical management, isolated distal phalanx, so finger promptly treated within 8 hours. So ideally within 1 hour of presentation and before surgical interventions. Okay, so here's the option. So IV antibiotics. Okay, we will do some other question as well. Yeah, other question as well. Then I will explain the difference. 27-year-old man brought to the emergency department after being involved in a motorbike crash 2 hours ago. Injuries in his left leg. He has no significant medical history and does not take any regular medications, and initial resuscitation performed based on the advanced trauma life support protocol to control active bleeding. And the maintain blood pressure, he is currently hemodynamically stable. A further repeated details assessment of the limb injuries performed on examination. There's a 7 centimeter long wound over the shin with clear deformity and angulation of the lower limb and fragment tibia visible. The fracture is reduced in the emergency department. However, the foot remain cool and pedal pulses are diminished. Which one of the following is most appropriate next step? So next step are IV antibiotics, wound debridement, reduction of the fracture. Then fourth option is fasciotomy. What do you think? What do you think, doctors? IV antibiotics, wound reduction, sorry, fracture reduction, then wound debridement, fasciotomy. What do you think? What do you think, doctors? What do you think? Quickly answer.
I think, doctor, it will be like,
What, doctor?
I'm sorry, my audio wasn't working. I'm sorry. I
I
think
have.
it's fasciotomy.
What about other
Pole
doctors?
and pedal pulses are diminished, and the shin with the clear deformity. So,
Okay, here. Okay, 1 minute. I'll explain. There's another question as well. Yeah. Okay. So here, why Dr. Fasciotomy? Is there any symptoms of compartment syndrome? Is there any signs or symptoms of compartment syndrome?
yeah, the pale, cold extremity and clear shin and
Mm-hmm.
pedal pulses are also diminished.
Okay. Okay, I'll explain here. Here, there is a neurovascular compromise, right? Neurovascular compromise. Okay, don't worry. I will explain here. The answer is immediate surgical referral for reduction. Okay, I just give the easiest way, the reduction. I will explain here. The immediate surgical referral is the most appropriate next step. Why? This patient has an open tibial fracture with hard signs of vascular compromise, a cool foot, diminished pulses. Despite initial reduction and stabilization, immediate surgical review is required to assess for the vascular repair and limb salvage. Okay, remember these points. Okay, we'll discuss third question and then all three together we will explain. Okay, here. A 55-year-old man brought to the emergency department by ambulance after being involved in a motor vehicle accident where he sustained soft tissues, wound deep to the back of his leg, and X-ray shows tibial shaft fracture reduced in ED with application of long back slab. The patient is taken to the theater that night for definitive management with external fixation. He is reviewed in the ward several hours after procedure and has increase in pain in the leg despite being given analgesia according to the standard protocol. The patient is agitated with blood pressure 156 by 90, pulse 104. There is a positive passive stretch test but not associated paresthesia or paralysis, and the pedal pulses are palpable. Which one of the following is most appropriate next step? Now tell me what is the next step. Mm-hmm. Okay, here what we can see, what is the diagnosis here, doctors? Like what is the, so not actually complications, yeah, compartment syndrome, right,
Yeah.
doctors? Okay, I'll explain here. So the concern must be possibility of the development of compartment syndrome. This can be devastating condition where osseofacial compartment pressure rise to level that decrease perfusion to muscle and nerves within the affected compartment. The most common situation where this develop in the long bone fracture where local trauma resulting in bleeding and edema, right? Here, so leading to increased interstitial pressure, vascular occlusion, and if prolonged, myoneural ischemia. The diagnosis is based primarily on the physical assessment of the patient with intact mental status and where the pain out of proportion clinical situation is the main symptoms, right? Classical 5Ps. Remember, pain, paresthesia, pallor, pulselessness, and paralysis. The pain is the earliest signs of compartment syndrome. Without intervention, this condition can lead irreversible tissue injury and Volkmann contracture. So the treatment on the ward is to remove all circumstantial resin and plasters. The leg is not to be elevated as this reduces the perfusion to the extremities. So adequate analgesia should be given promptly. Then contact must be made with orthopedic team and the here and need to do the emergency fasciotomy. Right? Can you understand three scenarios here? Can you understand? Is this compartment syndrome? Okay. Oh, we have from these fractures, we have two complications. One is neurovascular compromise, and two is compartment syndrome, right? Here, what we can see is Dr. Neurovascular compromise, right? Neurovascular compromise. Why? The patient is having patient is still okay. The fracture reduced in the emergency department. Okay, they have already reduced, and after also these foot is remain cold and pedal pulses are diminished. Okay, I have given the another option, so don't worry. But here patient is having foot remain cold and pedal pulses are diminished, right? Can you understand three different scenario? Actually, I gave the another option, so don't worry. Here I want to understand here, we can see neurovascular compromise, right? Neurovascular compromise. Why? Patient already done the initial reduction as well. After the assessment, we can see what? After assessment also, the foot is remain cool and pedal pulses are diminished, right? That means the neurovascular compromise is still present there, right? Reduction didn't help. So in that case, we have to save the limb and we have to save the perfusion. So immediate surgical reference should be done. Okay, reference should be done. Then in this case, we can see the pain out of proportion, right? After the reduction, right? Sorry, after the reduction and after the fixation, there is a pain out of proportion, and because of that, they have measured the agitated blood pressure increase and everything. And here the another one is positive passive stretch test, right? Positive passive stretch test. So it also positive here. So in this is the compartment syndrome. This is a neurovascular injury, right? Neurovascular injury. Neurovascular injury, we have to urgently we have to refer for surgery because we have to save the limb, right? Here we have to remove all the cloths, all the circumstantial resin and everything, and we have to consider about the fasciotomy because of the compartment syndrome, right? Here these two questions explain about these two scenarios, okay? And here this is how you should manage these open fractures. Open fracture management. If no neurovascular compromise in the initially, like in our first question, do you remember in our first question, patient is having palpable pulses, right? Palpable pulses, there's no diminish or no uh, cold or peripheral limbs, right? In first question here, that the question we got IV antibiotics, right? Here what we can see, the foot foot is cool, but foot can be cool, but pulses are palpable, right? Pulses are palpable here. So in that case, we can just follow the normal one anyway. First one is emergency ABC protocol, then analgesia, then IV antibiotics immediately, then tetanus, those other things. Then gentle reduction if needed, and sterilized saline, resin, and everything like the normal one. Okay, and after the reduction we have to repeat neurovascular check, right? Because after the second question, after reduction patient still had the low perfusion, right? Because of that we have to refer for the surgery. If neurovascular compromise present, what we should do, give analgesia, and there's a reduce pulses, everything present. We have what we should do, immediate gentle reduction first, right? Then we have to do the recheck pulses and perfusion. Recheck pulse and perfusion and IV antibiotics also immediately we have to give. But first thing first, we have to immediately reduction. We have to do the immediate reduction, right? We have to save the limb. After we have to recheck the pulses, right? Yeah, like that. Okay, remember, you can remember it's like this. Infectious risk important, so antibiotic early, but ischemia like limb death is present more urgent than infection, right? Perfusion first, infection second, right? Yeah. Remember like this, okay? These are two different scenarios because we were discussing this in our February recall class, and most doctors are went with here also antibiotic, right? Antibiotic. So that's why you have to identify. Here also they have done the initial reduction done. Then after assessment of the revascular state, then they have find out foot is still remain cold and pedal pulses are diminished. So because of that, we have to immediately surgical referral because we have to save the limb first, right? Then infection second, right? As the like, usual scenario, actually, like we have to give the antibiotic as well, but at the same time, referral is first. But during the surgery, we can before starting the surgery, we can give antibiotic as well, right? But for AMC, you have to know the algorithm properly, right? Yeah. Okay, we'll go back to our question. This one. Here, lower limb laceration, swelling, motor vehicle peripheral pulses are not palpable. So, X-ray done shows the tibial and fibula, I think, fractures. What is next? Initially, we have to reduce it. Then we have to recheck the pulse and like pulse are present or not. If pulse are present, then we can continue as the normal treatment. If pulse are not palpable after the initial reduction also, then we have to immediately refer this patient for surgery, right? Hope you understand it. Like everything, every single point, did you understand? Did you
Yes,
understand,
doctor.
doctors?
Yes,
Yeah.
doctor.
So keep this point in mind because March exam was a harder one. Because of that, you need to know everything, right? Like just we can go through everyone know reduction, right? But you have to understand what are the other complications, right? Like compartment syndrome, when neurovascular compromise, how it present, right? After initial reduction, we can check it, right? Like that. You have to know each step, so please be sure about like go through everything and understand every single point. Okay, next question. uh, yeah, here you can see February call. Okay, yeah. So, LBB, what to do? Okay, just we got like this. LBB, left bundle branch block, and what to do. And the options are temporary percutaneous pacemaker and permanent pacemaker. Just LBB only. I think like when we consider with the options, what you can think, doctor. Consider with the option, there's what is the other scenario that can associated with this LBB? Consider with the options. No, no, no. I'm not
Acute
asking the.
MI.
No, no. I'm not asking the answer. I'm just asking like when we considering these options. Okay, what is the what is the scenario is there can be some hard block, right? Because these temporary percutaneous pacemakers, permanent pacemakers, these are something we are using in bradycardia, right? Bradycardia, especially AV blocks, right? AV blocks. Because we just only get LBB and what to do. Why we don't know what LBB? Because LBB is associated with so many diseases, right? So many cases. Because of that, like isolated LBB, like we can't think because most of the cases they are associated with either MI, right? Like that. So because of that, you have to like consider here pacemakers present, so there can be AV block, right? Okay, first of all, we will discuss LBB and actually LBB. Okay, first thing. So you all know about William, right? William. What we can see in this William. So like to diagnose, to interpret LBB, we can understand this William part. And for the RBB, right one, we have marrow, right? So what does mean? William mean. So you all know W is the first letter and M is the last letter in William. So we are considering here V1, V2, V6, V1 to V6, right? And here, according to this William, V1 leads actually like a W shape, not they are given like a very good W. Just you can imagine it's like some W, right? That's why we call it William. Then V6 leads just like M shape. That means M, William M, right? Please remember this V1 and V6 leads, okay? Yeah, how it present. Then in the RBB, it's opposite side, right? We can see M in V1 and W in V6, right? Okay, this is from the life in the fast lane, life in the fast lane one. So here, these are the causes of left bundle branch block, right? So aortic stenosis, ischemic heart diseases, hypertension, dilated cardiomyopathy, anterior MI, right? So many things, and digoxin toxicity, right? So new LBB in the context of the chest pain was considered STEMI equivalent and part of the criteria for thrombolysis. However, more up-to-date data suggests that chest pain patients with new LBB have a little increased risk of acute MI at the time of presentation, right? Yeah. But practice has now evolved to examine for excessive discordance or concordance T segment changes in predictive of infarction. I will explain, okay? Because this part is very important. What do you know about precordance? Sorry, 1 minute. So this discordance and concordance. What do you know about this discordance and concordance? Because when there's a LBB with heart chest pain, we have to think about MI, right? We have to think about MI. For that, we need to know about this discordance and concordant. So what do you know about discordant and concordant? Tell me, doctors. Do you have any idea? Don't worry, I will explain. I'm just asking whether do you have. Okay, if you don't have, just tell me no. There's no one here to judge, okay? Yeah, good.
I have no idea, doctor.
Yeah, doctor. Okay, yeah. So let's discuss here. And I have attached this one. Does bundle branch directly cause the bradycardia? Okay, remember this one because in our case seems like related to bradycardia when we consider with the options given. So here in most cases, BB bundle branch block does not directly cause bradycardia. However, it may be a marker of conduction system disease that can lead to slower heart rate. So isolated BB and heart rate. So an isolated RBB or LBB often does not affect the instinct rate set by SA node. The ventricles may be still activated, albeit less efficiently. The presence of BB does not usually result in fewer beats per minute unless they involve into a high grade block. Like when we can think about that can be a complete heart block, right? Because usually it can associated with the high grade block if it is the cause cause is a bradycardia, right? Yeah, so remember these points, okay, because otherwise these are most associated with cardiomyopathies, MIs, like that. Okay, so what are the ECG diagnostic criteria? And you should know about QRS duration more than or equal to 120 millisecond, right? Then dominant S wave in V1, dominant S wave in V1, okay, here. Then broad monomorphic R wave in lateral leads one AVL and V wide V5 to V6, absence of Q waves in lateral leads and prolonged R wave, peak time more than 60 milliseconds, leads in V5 to V6. Just remember about the William criteria and QRS duration more than 120 millisecond, right? Remember, I will explain here. Okay, here dominant is wave. We can see. Yeah. Then broad notch M shaped R. Yeah, we can see. R wave, sorry, M wave here and W wave here. But in most of the cases, they are not like clearly giving this William like proper W and M, right? Mm. And other things we can see left axis deviation, right? Poor R wave progression, like that. Here also they have explained the same thing, M and this William thing, right? So yeah, okay, QRS complex. Okay, this is the another part. I'll explain. So QRS morphology in V1. What we can see, doctors? What we can see, RS complex. That means small R wave and deep S waves. Like small R waves and deep S waves. Not very clear. But here you can see there's something like W shape, right? Like that. Then QS complex, like deep QS wave with no preceding R waves, right? Like that. Just easily remember William, okay? Okay, this is the most important part now because in previously, like when patient presented with chest pain and these LBBs, we have to treat it as a ischemia, right? But currently, we have something else, discordance and concordance, right? I will explain here. So what in the T segment movement in the opposite direction of the QRS, this chord discordance. Don't worry, I will explain. This happened because ventricular depolarization in abnormal in LBB. So the repolarization ST also become abnormal. That mean, okay, read this one and I'll explain. So we worry about MI when there's a concordance. Concordance means same side. Discordant mean different side. As example here. Okay, this is for the infarction. For concordance, if QRS are up, ST also up, right? ST also up. If QRS going down, ST also going down. But in LBB without MI, what we can see, QRS up and ST down. Here, if QRS down, ST is up. That is what? That is discordance. But in MI associated with LBB, it's a concordance. Okay. That means discordant ST changes here normal in LBB and concordant ST changes suspected in MI, right? So do you understand what I'm saying? Do you understand about concordance and discordance? Everything is clear? Quickly answer. Okay, right.
Yes,
Please
doctor.
remember, yeah. Okay, I'll show a example, then you have to answer this, okay? And you have to tell me what we can see in here. 65-year-old man presented to the emergency department with 2 hours of central chest pain radiating to his left arm. He has a history of hypertension and hypercholesterolemia. His medication include amlodipine, atorvastatin, and he is an ex-smoker with 30-pack year history. On examination, he appears uncomfortable. Pulse rate 88, BP 165 by 95, respiratory rate is 20, SpO2 98, temperature 36.7, heart sounds are normal with no added sound. The chest is clear to auscultate. ECG performs. Okay, this is the ECG. Here, which one of the following is most likely ECG diagnosis? And now tell me what you can see in this ECG as well. Okay, yeah, left bundle branch block. You all know because we are discussing left bundle branch block, right? So now tell me what you can see. Okay, M wave in V6. Where's V6? Okay, M wave in V6 and what else? What else we can see here? Okay, opposite direction of QRS and ST. Mm-hmm.
But in V1, it's not like W, it's in the upward direction.
No, doctor, we can
Like,
think about it's as a W like this, okay? Like like this. It's also W, okay? That's why I told you, like most of the case here, can you see here?
yeah.
Like, like that. Here also W, you can see another this one. Okay, like that. It's like they are not giving proper W, right? This is ECG, right? The W we are using to remember it, right? Okay, what else we can see here? Okay, discordance, right? In this broad complex, yes. So yeah, this is, yeah, good doctor. You remember, you have understand it, right? Yeah, good. So this is left bundle branch block here. ECG shows characteristic features of LBB, and yeah, occurs when the delay of blocking the conduction electrical impulse, QRS more than 120, broad monomorphic R wave in lead 1, AVL and V5, V6, absence Q waves in lead 1, V5, V6, like that. You can give it a read. And appropriate discordance STT wave changes like ST segment and T wave point in opposite to the remain QRS reflection, right? So please give it a read later, like, about other how to differentiate from here, right? Yeah. So you all understand it, right? So let's go back to here. So here LBB, what to do? Like considering the options, this can be a complete heart block or bradycardia, some AV block, right? Some AV block. So how we should, okay, tell me, for the complete heart block, how we should treat, doctors? Tell me the treatment of
Permanent
complete.
pacemaker
Okay.
or complete.
Okay, if the pacement is delayed, what we can do?
If the placement is
Delayed.
delayed,
Yes.
uh, I don't know,
And if
doctor.
if the okay, if the patient is unstable, what we can do? You should know, right? Every single point, what we can do. Mm-hmm. Okay. Tell me, okay, you should know three scenarios. Mm. If the patient is unstable, what we should do? Okay. Okay, what about other doctors? Quickly answer. Because like if the patient is unstable, can we do the permanent pacemaker insertion? These are the points, doctors. Can we do if the patient is unstable? Can we do permanent one? No, right? Yeah.
I think no,
Mm-hmm.
yeah.
Yeah, okay, remember. So you have to remember about that. Okay, if the patient is unstable, initially we are using temporary pacemaker, right? Temporary pacemaker, then stabilize the patient, right? Stabilize the patient, and then we can do later the permanent one. Okay, if the patient is stable and the these any patient like temporary or permanent, everything is delayed, then what we can do? We can give atropine, right? And we have if the atropine is not in the options, what are the other things that we can do, doctors? What are the other things that we can do? Atropine is not in the options, and these patients are delayed. What we can do? Quickly answer. I have explained everything in our theory classes as well. What are the other options that you can use? What do you know about IV adrenaline? No IV isoprenaline? Dr. Abab, where are you? Do you remember? Isoprenaline or IV adrenaline, right? Yeah, you have to understand this, right? Yeah. Mm-hmm. Everything mentioned in where? Everything mentioned in where, doctor? In therapeutic guideline. Do you remember? My God, I have explained multiple times in our theory sessions as well. If you are new to our this session, it's okay. But I have explained every bradycardia in our theory session, right? Yeah. Okay. Here. If pacing delayed or not immediately available, consider using isoprenaline or adrenaline according to a local protocol. The local protocol is not available. The suitable regime is adrenaline 2 to 10 micrograms per minute by intravenous infusion and titrate according to the clinical response, or isoprenaline 2 to 10 micrograms per minute by intravenous infusion, titrate according to the clinical response. Right? Hope you remember now. Right, doctors? Is everything clear? Please go and do all the bradycardia MCQs, okay? All the bradycardia MCQs. Then you will understand, okay? Mhm. So I'm not marking anything here because we don't know patient situation and everything, right? Yeah, situation and everything. You have to answer according to the scenario, right? Yeah, I'm gonna move. Have you understand? Just tell me. If I am asked question, just type in the chat. You understand or not? Yes or not? Right? Yeah, you understand. And you have a task to do all the bradycardia questions after the session, right? Okay, of all the bradycardia questions you have to do. Otherwise, you can watch my bradycardia theory session. I have explained everything with recall, not recalls, actually emergency questions, right? So please go and watch that as well if you have any doubts. Okay, yeah. Okay, next question. Okay, we'll go to just 1 minute. I have marked the answer in there because this is my February, not March file. Okay, just 1 minute. Okay, here's the question. Parathormone low, calcium high. The management due to malignancy, hydration, commenced other. What do you think? How we should treat malignancy related, what malignancy related hypercalcemia, how we should treat, doctors, how we should treat. Mm-hmm. And what are the doctors? Okay, have you listened any of my hypercalcemia session? Have you listened any of my hypercalcemia session? Have you listened any of this? My doctors, we have done many times, right? Yeah, because it's a very important one. Okay, if you have not listened, please go and check because we have I think we are discussing the not sure emergency as well. You can find it in the YouTube. Okay, I'm just telling. Yeah. Yeah, okay, it's fine. I'll explain here what you can see. I quickly explain. Okay, this is a huge topic. Mhm. Okay, yeah. Yeah, in the option they have already done the hydration, right? So you should know about how normal calcium regulation present, right? It from parathormone, vitamin D, and bone turnover, right? If you have not watched that, it's like a 20 minutes video. Go and check. Okay. Here, normal calcium regulation by parathormone, vitamin D, and bone turnover, right? We all know parathormone is the here the main character, right? What parathormone can do? Parathormone can increase the calcium resorption from kidney, right? Then increase bone resorption and increase vitamin D activation. Then active vitamin D can increase the calcium absorption from the gut, right? This is the three things that increase the calcium level. Three mechanism increase calcium level in our blood, right? Yeah. Then what is the pathophysiology of hypocalcemia? It can be due to increased calcium resorption from kidney, right? Or it can be due to increased bone resorption. No, it can be due to this increased gut calcium absorption, right? This is the three main mechanism that we can see in hypercalcemia, right? Yeah. So, and you should know about this hypercal. Sorry, then you should know about what are the causes, right? What are the causes? And we'll discuss about primary hyperparathyroidism. This is the most common cause for hypercalcemia, right? The cause by what? Parathyroid adenoma. Okay, parathyroid adenoma. How it cause? If there's a cancer in parathyroid gland, what they can do? What they can do, doctors? They can produce excessive parathormone. If there's a adenoma in parathyroid gland, they can produce excessive parathormone, and this excessive parathormone uh, act on their three main mechanism, and they can increase the result as a increased level of calcium, right? In here, parathormone is high because this adenoma inappropriately produce this parathormone, right? The next other we have malignant related hypercalcemia, right? Malignant related hypercalcemia. What is happening in malignant related hypercalcemia, doctors, in malignant related cases? Here also we have two mechanisms. It's not associated with parathormone, right? Not associated with parathormone. How it associated? Usually, in we have something called parathormone related peptide. Some cancers, as example, lung cancers, breast cancers, they can produce some peptides, right? They can produce some peptides that actually like a parathyroid hormone, but they are not actual hormone. They are just peptide that act as parathyroid hormone, but they are not actual parathyroid hormone. These are like fake ones, right? Fake ones, but they are doing the same thing as parathyroid hormone. Because of that, calcium can be increased. But here, the real parathyroid hormone is suppressed, right? Because these are fake ones. So then other than that, this is the one mechanism, and the second mechanism is bone metastasis, right? If tumors invade the bone, then direct osteolysis can see. Because of that, calcium can be released from the bones, right? Yeah. Please keep these points in your mind. Then, due to vitamin D excess, there can be increase the level of calcium by increasing absorption in gut, right? The reduced renal excretion, so excretion reduce, then they are absorbing into the blood, right? Yeah, like that. Okay, this is from the therapeutic guideline. Okay, and you should know about, when we discuss about the causes, we have parathormone dependent one and parathormone independent. Dependent mean, you all know, dependent means due to parathyroid hormone, right? There can be primary parathyroidism, hyperparathyroidism, like that we just discussed. Then the dependent one due to vitamin D excess immobilization. The same thing we have discussed here. We are divided into two categories, right? Parathormone dependent, parathormone independent. Independent, you can remember it as like this: vitamin D, immobilization, thyrotoxicosis, malignancy, milk alkali syndrome. So the sarcoidosis, these are the independent one. There's no connection with parathyroid hormone, right? Yeah. Then what are the clinical symptoms that we can see? You can remember it as stones, bones, psychic moles, abdominal groans, right? Like that. So stones mean because of increased level of calcium, we can see renal colic and hypercalcemic stones, right? Yeah. Then bones increase the osteolysis and fractures. Then psychic modes mean depressions, confusions, hallucinations, coma. Abdominal groans mean anorexia, nausea, vomiting, constipation, PUD, pancreatitis. Like other features are muscle weakness, malaise, hyporeflexia, confusion, neurogenic diabetes insipid, like that. Okay. Then the next important part is stepwise investigation, because I think in March 2025 March, I think. Yeah, I think 2025 March, they have asked us to about this stepwise hypercalcemia diagnosis, right? First of all, we have to confirm the hypercalcemia, right? Anyway, then what we should do next, we have to check the parathyroid hormone level. Why? Because we can categorize them into parathormone dependent and parathormone independent, right? Then it's very easy us to like understand if it is parathormone dependent or independent, right? In parathormone dependent cases, okay, I'm asking a question. In parathormone dependent cases, is parathormone level increase or decrease? Parathormone dependent cases
Increased.
increase. Okay, what about other doctors? Hi, good, right? Yeah, I want to understand, like, you actually get the point. Okay, if parathormone level independent mean, then parathormone level increase or decrease? Independent one? Independent one?
It can be normal as well or decreased.
Yes. Yeah, doctor, it can be normal. Usually can be normal or decrease as well, but usually, yeah. Like there's a no abnormality in parathormone level, right? Yeah. Okay. Remember about usually malignancy, everything. Okay. So if there's acute severe hypercalcemia, how we should treat? We have initial rehydration. This is the most important part, the rehydration. Remember rehydration. If you see some hypercalcemia, first thing in your mind is rehydration, right? Rehydration. Here what you can see, sodium chloride 0.9%, 4 to 6 liters by intravenous infusion over 24 hours, right? Yeah, like that. Yeah, the other things are additional treatment. Additional treatment, if severe hypercalcemia and child does not respond to adequate to rehydration, you have to refer. If it is a pediatric case, you have to refer. An adult case with severe hypercalcemia or any cause, okay, that has not responded to dehydration, consider using intravenous bisphosphonate infusion to temporarily lower the serum calcium concentration. And before starting the bisphosphonate, take a blood sample, measure the patient's parathyroid hormone concentration to help determine the cause, right? According to the stepwise investigation. So we can use zoledronic acid and pamidronate, right? Okay, this is the management. And yeah, and in the therapeutic guideline, they have clearly given another part from hypercalcemia associated with cancer, right? Here. What we can do, doctors, here principles of management of hypercalcemia associated with cancer, like in our case. Always review the patient's medications and consider stopping or reduce the dose of drug that exacerbates hypercalcemia, right? If the patient is taking some supplements, we have to initially stop it. Then severity of symptoms and therefore urgency of treatment is determined by the degree of hypercalcemia and the rate of rise of the serum calcium concentration. And the urgent treatment is generally not required for asymptomatic hypercalcemia or hypercalcemia with a serum total concentration corrected albumin for less than 3, right? And here you have to remember the serum calcium concentration above the 2.6 is associated with many types of cancer, particularly squamous cell cancer, breast cancer, multiple myeloma, like that. Okay. And the treatment, initial treatment of symptomatic hypercalcemia associated with cancer is intravenous rehydration. Even though it's related to cancer, rehydration is the first thing. Addition of bisphosphonate may be required. So what we can use here, okay, for this is for dehydration. Bisphosphonate. What is the indication that we can use bisphosphonate? After initial intravenous rehydration, consider bisphosphonate for patients with hypercalcemia associated with cancer who have you should know these 2 points, who have serum total calcium concentration corrected for albumin is 3 millimoles per liter or higher. Symptoms and serum total concentration corrected albumin between 2.6 and 3, right? So hope you understand these 2 points. If the with the symptoms with between 2.6 to 3 or serum there's in here. Anyway, the symptoms doesn't matter. If the patient is having more than or equal to 3, you have to anyway start after initial rehydration the bisphosphonate, right? So that's their telling. So what are the bisphosphonate that we can use? Pramidronate or solendronic. Solendronic here, right? And when the bisphosphonate therapy is effective, the serum calcium concentration usually start falling within 3 to 4 days, with maximum effect at 4 to 7 days, and duration of effect is between 2 to 4 weeks, and consider repeating the dose if hypercalcemia reoccur, and treatment is clinically appropriate. So let's go back to our question. Hope you understand everything. Yeah. Okay, this is the March recall. Okay, here. This is the March recall. Okay, 2025. Not this one. A woman with history of breast cancer, which was treated 5 years ago. Investigation given only abnormalities, hypercalcemia. What is most appropriate next investigation? So we have understand there's a hypercalcemia. So next investigation is we have to check parathyroid hormone level to identify this parathyroid hormone dependent or independent, right? If it is independent, we can think about the due to cancer, right? Metastasis cancer. And yeah, this is the February call. A patient with lung cancer coming with dehydration, high calcium level 3, right? 3 is high level, and regenerate investigation profile. Potassium 5.6, creatinine slightly elevated, ECG reduced PR interval with Q waves. Then after giving IV fluid, what is next? Immediate management. You can give this bisphosphonate after initial IV fluid. Then you can use pamidronate. Here they have just given bisphosphonate, so we can take it as a bisphosphonate, right? And doctors, but always think about the criteria in cancer patients where we can use, right? Where we can use this bisphosphonate therapy, right? Hope you understand everything. We'll quickly move to the our next question. Okay, melanoma in eye, like they are repeating this question in most of the months, right? Melanoma in eye, you can see like this kind of picture, okay, this kind of picture. So always, if it is in eye, always you should refer or specialist or plastic surgeon, right? Sometimes even in my exam, I got refer for a plastic surgeon, right? In November, refer for the plastic surgeon. So I have attached both. Anyway, remember the word refer if it is in I, right? Okay, very easy. Next one, SLE treatment. HCQ was started asking about what else option were. So actually, SLE patients. So we'll discuss little bit about SLE. Now tell me how these SLE patients present. What are the signs and symptoms of SLE? Quickly type in the chat. Everyone should answer, okay? Because active participation is very important. Type in the chat what we can see in these SLE patients. Okay, tell me specific features only. Okay, the mala rash, right? Serositis. Okay, and we have discoid rash. What else? Yes. Yeah, good. Yeah, I have attached this one as well. This soap brain, right? Soap brain. Actually, sometimes this is for me it's kind of hard for this soap brain thing. I just remember the symptoms, right? Yeah. Okay, you can use anything that better for you, right? So you can, if you want, you can use this soap brain MD. I have attached this one as well, and therapeutic guidance. We are very clearly given a uh, table. Okay, so what we can see, constitutional symptoms, we can see fatigue and like more specific in SLE, patient can have unexplained fever. Doctor, after the session, I will upload this file with the recording. Okay, upload this file with the recording, usually within 1 hour, or sometimes it will take more time because if I need to add some other options, then I will share the drive link. Like after the class, please share your email address in the group. Then I will no, doctor, not Telegram group because, like previously in November and October, I have given Dr. Rabab and you were there, right? Yeah, I have given option as a downloadable file. Usually, no one is given downloadable file like this. My file is very informative, right? And you all can see how much hard work I am doing for these classes. So I have given the downloadable access, and there were like I think 40 or 42 doctors in our November November like same this kind of recall revision class, and I have gave access because I know how hard it is like using a non-downloadable file, because actually it's very easy. We have a downloadable file, then we can add the references and everything. Like I was thinking from my side, because I have faced so many difficulties when I was preparing when there is a no not a downloadable file. Because of that, I gave access to anyone in our November recall session to downloadable file. Then in October as well. I gave 2 months. You know what happened? Some doctors in November recall group, they have shared outside the file out of respect, right? Out of respect, because I was thinking about from your side, and I, because this is the very cheap class, right? You can see I'm taking like I'm doing classes for like 10 days and just charging like 75 AUD, and I'm doing this for very cheap because I know how expensive is the MC exam, right? Because I was thinking your side, because I also had so many problems when I was preparing, because everything is very expensive. Right, then some doctors have shared it outside, and then I got find out them like they have like shared outside out of respect, right? Without my permission. Because of that, I have restricted by giving the downloadable. I'm actually so sorry for that, because you are not responsible actually. Because of that, I have to restricted that. Yeah, so you are getting the file, but in non-downloadable form, because of that security reason. Okay, yeah, thank you, doctors. Yeah, because I want to explain, because you all are new. Because other doctors in previous sessions, they are very, very familiar. They are like my family, right? Dr. Rabab, Dr. Kumari, because we were having like many months of discussion like this, and they all know what happened, right? Yeah. Okay. Yeah. Okay, so we'll discuss. So, constitutional symptoms, non-specific features of fatigue, but in Dr. Turkey also there, right? Yeah, yeah, you also there, right, doctor? Yeah, yes, I remember. So, unexplained fever. Then, cutaneous and mucosal. So, rash, photosensitivity, oral and nasopharyngeal ulcers, Zika symptoms we can see. And more specific to clinical is LCLE is the mala rash, right? I'll show picture, because sometimes they are giving the this mala rash picture, or we call it butterfly rash here. Can you see? Yeah, this is the rash. Okay. Yeah, so then we have non-scarring alopecia and hard palate ulcers can be seen. Then musculoskeletal arthralgia, myalgia, and here we have inflammatory arthritis in two or more joints, right? Then vascular, we have non-specific features like Renault phenomena, and specific features are premature atherosclerosis, cardiovascular disease, and lupus associated with vasculitis. Then serositis is a very important in here, serositis part. So we have pleuritis, pleural effusion, acute pericarditis, pericardial effusion, peritonitis, like that, right? Then hematological, we have positive antiphospholipid antibodies, and in here we have leukopenia, thrombocytopenia, hemolytic anemia, then antiphospholipid syndrome, neuropsychiatric, psychosis, seizures, delirium, neurocerebral vasculopathies, then kidney, we have hematuria, proteinuria, lupus nephritis, those are the features, okay? Then you should know about what are the specific antibodies that we can use. Thank you so much, Dr. Rava. Yeah. Here you should know about the lupus antibodies. So what are the specific for here? In this part they have given everything related to other vasculitis and other connective tissue disorders as well. So you can give it a read. I'm discussing only about the specific one for the lupus, right? So here what we have DS, DNA. highly specific for SLE associated with lupus nephritis. Then we have anti-Smith, right? Highly specific for SLE, not associated with the disease activity. And please remember, and we have something else. We like I know you everyone know about anti-Smith, right? Anti-Smith, and there's a something we called uh, this one, anti-smooth muscle antibody, the SMA. SMA. So please don't confuse this anti-Smith and anti-SMA because these are two different things. Okay. So anti-SMA can be seen in autoimmune hepatitis, right? But not in SLE because this can be confusion. That's why I'm telling. Anyway, anti-nuclear antibodies is highly sensitive but not specific for this disease, right? And present in many autoimmune disease. Very, very sensitive but not specific for lupus, right? Yeah. And I'm not discussing other things, anticardiolipin, anti-Rho, anti-La. This is associated with anticardiolipin, antiphospholipid, ROLA with such organ syndrome. Rheumatoid factor with can be present in SLE, but mostly can see in rheumatoid arthritis, right? Yeah. Then the treatment is most important one. Please listen this carefully. Yes, please listen this carefully, right? Okay. Like in SLE, all the cases, all the patient with SLE, the initial treatment, the first line treatment is hydrochloroquine. Hydrochloroquine. Like if the patient presenting with any kind of SLE, but there's a one exception. I will explain that one as well. Okay. Hydrochloroquine is the first line. As example, patient is having SLE diagnosed, right? And patient is having severe organ damage as well. In these case also, okay. Anyway, like if we need, if in like if a sinusitis present, either we can have some other arthritis, right? Severe arthritis. Even though any cases in any time we have to add other drugs to this hydrochloroquine. It's always hydrochloroquine plus something else. Hydrochloroquine plus something else, right? Can be prednisolone. It can be methylprednisolone. Sorry, yeah. Sorry. Can be methotrexate like that. Always hydrochloroquine should be there. In addition to hydrochloroquine, we are adding other drugs for other treatment, right? Here, hydrochloroquine is usually the first drug for all patients with SLE, and systemic corticosteroid very commonly used in combination with hydrochloroquine, an immunomodulator drug for severe organ or life-threatening. What doc? Why? Yeah, doctor. What is the problem?
Doctor, I have one question.
Yeah, doctor.
Um, like if in this scenario, if the patient is presenting with only just rash, but
Yeah, yeah.
not
Yeah, I will
arthritis.
explain.
So,
That is the only exclusion, okay? That's the only
uh,
exclusion I was mentioned. I will
okay.
explain because I know I have explained it I have added in our February and I know. I will explain,
Yeah.
okay? Just wait a
Okay.
few minutes. Yeah,
Okay.
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 Yeah,
Thank you.
yeah, sure, doctor. Okay, for now, remember this. Okay, for hydrochloroquine is like always there. Okay, but there is a one exception. I will explain it later. Okay, here, and you should know like what are the scenario that we have to add other drugs. So, as example, okay, here where we should add systemic corticosteroid for SLE. Where? Okay, so these systemic corticosteroids are commonly used to in addition to hydrochloroquine for severe organ or life-threatening features in SLE. Like SLE associated vasculitis, lupus nephritis, but they are usually not requiring for mild disease, right? Depending on the features of SLE patient, patient may be started on pulse, intravenous, or high dose oral corticosteroid, right? Here, patient with severe features of SLE may require initial treatment with pulse intravenous methylprednisolone, the usual dose for. Here you can give it a read. Then high dose oral corticosteroid are indicated for severe SLE, either initially or following a pulse intravenous therapy, right? Then oral corticosteroids are indicated in mild features of SLE like a rash, arthralgia, and much lower dosage is recommended like prednisolone, right? Okay. In arthralgia, patient present with arthralgia, then we can think about these oral corticosteroid because it's a mild case, usually mild cases, right? Keep these things in your mind. Then you have what you have DMARS. DMARS. When we are using DMARS, and DMARS also we all know we have conventional synthetic DMARS and we have biological DMARS, right? So here, where we can use these methotrexate drugs, where in severe arthritis, here severe arthritis in SLA would be preferably treated with methotrexate in addition to oral hydrochloroquine, right? Everything is addition to this hydrochloroquine. 1 minute. Yeah, sorry for that. Yeah, remember in severe arthritis present, think about methotrexate. And if you are giving methotrexate, you have to give the folic acid acid, right? Keep these points in your mind. So what is the problem, doctor? Anyone in May, anyone April? Yeah, we have May doctors and April doctors. Yeah, you can ask in the our group. Then you can connect with them. Okay. Yeah, I don't think now everyone is focusing on the this session, and yeah, I don't think they will reply. So you can ask in the group. Then okay, then uh, we have some other features like hematological features of SLE like hemolytic anemia. If hemolytic anemia present, we can add acetioprine. Where we can use mycophenolate, where we can use mycophenolate may be used in addition to the oral hydrochloroquine to treat significant lupus nephritis. The use of dosage is here. So if there is a lupus nephritis, we can add mycophenolate, right? Yeah. Then what else? Cyclophosphamide remain in use for adult with SLE, but other immunomodulatory drugs are preferred over these cyclophosphamide. Okay, please keep in this mind. Then tractarimus may be used in addition to oral hydrochloroquine in treat to significant lupus nephritis. Remember. Then this biological one when we should use doctors. The role of biological DMARDs in SL is unclear, but B-cell modulating therapies like rituximab, belimumab are most commonly used in other biological drugs like TNF inhibitors have not been useful. These are like a second line drugs, okay? This biological one. Then, yeah. What else? Yeah. Then we have serositis. Very important, this serositis part. Yeah, doctor, actually for this one, yeah, I don't have a like a short note. Yeah, actually, I also like write down somewhere like serositis present like that, but I think I have like I don't have write it now. Yeah, that's a problem. Okay, I'll try to make it possible. Let's see what we can do in the future. Yes. Yeah, then we have serositis in SLE. Like you can write it down, right? Like serositis in acute cases. What we should do here in acute severe serositis associated with SLE, we can give what? We can patient with pericardial or pleural effusion or peritonitis usually respond rapidly to the pulse intravenous methylprednisolone, right? Then high-dose oral corticosteroid indicated in severe serositis in SLE the initially or after this pulse therapy, right? Then in mild serositis, NSAID are just enough, right, to control the pain, right? So keep these points in your mind. Then you should know about these neutropenias. So, patient with SLE, minor reduction in blood cell count, do not necessarily require treatment. However, if cytopenia is present, here, if cytopenia associated with SLE is progressive or severe, refer patient urgently to the rheumatologist. So we have to refer this patient if cytopenia present, right? Okay, yeah. And the next part. So you have to answer this question, then I will explain. A 28-year-old woman presented to the GP clinic with 4 months history of red scaly patches on her face and rash is photosensitive and mildly itchy. She had eczema as a child but has any skin issues since age of 6, right? Then age of 6 years, she feel otherwise well. She take no regular medications. On examination, she appears well with vital signs within normal limits. There are erythematous, slightly red, scaly plaque with minimal scarring across her cheeks and nose in a butterfly distribution. The rest of her skin examination is normal. Which one of the following is most appropriate initial management? What do you think? Mm-hmm. Yes. Okay. That is the point I want to explain. Okay. This is the point I want to explain. Here, the answer is topical betamethasone. Okay. Or in this presentation, the classic features of cutaneous lupus erythematosus, specifically discoid lupus erythematosus in typically butterfly distribution. In patient with suspected cutaneous lupus erythematosus assessment involved the fully history physical examination together with appropriate laboratory investigation to determine the presence of extent of systemic disorder. So disease, testing for anti-nuclear antibody, extractable nuclear antigen, then double strand DNA and complement C3 and C4 level is required to determine the presence and extent of systemic involved. Skin biopsy, histology, and direct immunofluorescence confirm the diagnosis. If cutaneous lupus is suspected, early reference to dermatologist or rheumatologist is recommended of to confirm the diagnosis and management. So topical betamethasone is the most appropriate initial treatment for local CLE according to the therapeutic guideline for initial treatment of localized thin or mild plaque in cutaneous lupus erythematosus, a potent corticosteroid such as betamethasone, dipropionate, 0.05% ointment applied once daily until skin clear for an initial period of 4 to 6 weeks is recommended. Under specialist guidance, potent typically corticosteroid can be used on the face for cutaneous lupus erythematosus. So why not oral hydrochlorine? It's a specialist treatment option reserved for cases that fail to respond in topical therapy, have widespread involvement, or show evidence of systemic disease, right? According to the therapeutic guideline, if the response of localized lesion or intralesional corticosteroid injection is still adequate, or if the patient represent with extensive cutaneous disease, severe flares or signs of scarring alopecia, refer this patient specialist and where may be hydrochloroquine may be considered. Hope you understand. If the presentation is only cutaneous, only like local presentation present, we are not giving initial this oral hydrochloroquine, right? This is a cutaneous lupus, right? Cutaneous lupus, and here what we can give is topical steroid as the initial one. If it is not working, then we can think about systemic steroid, right? Hope you understand. You have to remember these two different cases. Like actually, the cutaneous one, the only one that the treatment is a little bit changing. Hope you understand it, doctors, because we have discussed this one in February 5, right? Is everything clear? Everything clear, doctors? Okay, here actually we don't know what they are asking. Just they asked. Yeah, they are just mentioned something XCQ was started. That means they have confirmed there is a Lupus, right? There's a lupus. I started asking about what else option were because we don't know if the patient presented with severe arthritis or severe organ damages or serositis. We don't know anything. So because of that, we can't mark any answers. So you have to look for the clinical presentation of the stem. Then according to that, you have to choose it, right? Yeah. And so. And here cutaneous one also, oh no, cutaneous one are given in different way. First they are usually topical one, then only we give with oral hydrochloroquine, right? No, that's all for SLE. It's not a hard topic, very short and sweet. I know, like you have to remember so many things, but it's not a hard topic, right? Yeah. Okay, doctors, we will take 10 minutes break. Then we will meet. It's now 2:42. We will come at 52. Okay. Hello, doctors. Hope you all back after 10 minutes of break. Yeah. Okay, we'll continue. Yes. Okay. So next question. The same question about patient on enoxaparin 40 milligram after operating developed small pulmonary embolism, but the option were stop enoxaparin, start warfarin, increase enoxaparin to 80 milligram. For these three options, tell me what is the answer? Because this is a very AMC's very favorite question, right? Very favorite question from AMC. This one. Okay. I'm asking, okay, just forget these options. Just forget this option. If patient presented with small pulmonary embolism and patient on enoxaparin 40 milligram, and they're asking what is the best next step. Then what is the best next step? Okay. Dr. Abab, good. Dr. Grace, you remember, right? We have discussed this one in February, November, right? Very, yeah, very very common AMC scenario. Okay, I will explain here. We will do this question, then you will understand. Here, 76-year-old woman present to the GP clinic 5 days after an elective thyroidectomy with a 1-day history of mild bilateral pleuritic chest pain. She has no significant medical history and take enoxaparin 40 milligram daily for post-operative thromboprophylaxis. On examination, she appears well. Her pulse rate is 80, BP 130 by 90, respiratory rate is 60, SpO2 96, and temperature 37.2. Oscillate, 37.2. There's a frictional rub on the right side with no other abnormalities. The CTPA confirms several small bilateral pulmonary emboli. Renal function is normal. Which one of the following is most appropriate management? So now tell me the answer. Now tell me the answer, doctors. Then I will explain. Doctors, what is the answer? Very good, very good. What about other doctors? Dr. Grace, Dr. Abab, Dr. Turkia, Dr. Sandali, yeah. Those doctors are from my previous class as well. Yeah, we have discussed, right? Yeah, other doctors also get the answer correct, right? Here. Okay. You should know something here. The patient present with small pulmonary emboli following recent surgery despite prophylactic anticoagulation give her hemodynamical stability. A small clot burden outpatient management with oral anticoagulation is appropriate. Right, so stop enoxaparin and commencing apixaban is the most appropriate management. Direct oral anticoagulation now first line treatment for pulmonary embolism in stable patient. Stable patient, right? Not hemodynamically unstable patients, right? Please keep those points in your mind, okay? Okay, now tell me if the patient is presenting, okay, patient is hemodynamically unstable and patient is presenting with massive pulmonary embolism, what should be the treatment? Tell me what should be the treatment, doctors? What should be the treatment? Quickly answers. Because pulmonary embolism I have discussed in my theory class, right? I have discussed in my theory class as well. Then I have explained three different scenario, right? Good. Like three different scenario. But the massive pulmonary embolism, submassive pulmonary embolism, and what else we have? We have low risk pulmonary embolism. Okay, here. Anyway, we have, if the patient is unstable, we have to initially oxygen ABC, we have to follow, right? Okay. Then you should know about high risk patients or for massive pulmonary embolism. Consider thrombolysis with IV heparin when the patient shows the persistent shock or sustained hypotension. Avoid thrombolysis if the patient has a major bleeding risk, and if thrombolysis cannot be used, surgical or catheter directed clot removal is needed, right? Here. And here you should know how massive PE present. Usually patient is hemodynamically unstable. Usually with the unstable sign, we are taking it as under massive pulmonary embolism, right? Immediately intravenous heparinization, right? Systemic intravenous thrombolysis. If only patient can take thrombolysis, right? There's a we have to consider patient's bleeding risk as well, right? Then other support, respiratory support, vasopressor support. Like initially they are asking immediate IV heparinization. Then intermediate risk group or submassive one. Here submassive one, the pulmonary embolus with evidence of right ventricular dysfunction, but hemodynamically stable. These patient hemodynamically stable. In that also we have to provide anticoagulation here. Then suggested treatment, we have intravenous heparinization, recommended management, submassive one, right? Then systemic intravenous thrombolysis, here not routinely recommended, but patient potential to administer thrombolysis in selected patient with acute pulmonary embolism who deteriorate after starting these anticoagulation therapy, right? But but have yet to develop hypertension and have a low bleeding risk. Please remember the low risk pulmonary embolisms. In low risk cases, we can just use anticoagulation. Patients are stable, and there are like after CTP also there are small pulmonary embolisms like that. Like in our case, like it's a low risk case, right? Then we can go with oral anticoagulations, and you should know about when before giving apixaban and rivaroxaban, you should know about this creatinine clearance level, because according to that only we have to choose the drug, right? For apixaban, creatinine clearance level 25, and for the rivaroxaban it's 30, right? So please keep those two in your mind, because this is from therapeutic guideline. And other than that, we have to give supportive care, like treat the pain, expedite support if needed, right? Like that. Okay. So please keep those points in your mind. Okay, these are very important. So in our case, it's a patient is stable and they have identified there as a small bilateral pulmonary emboli. So because of that, we can just give oral anticoagulation. I wanted to show you because in every cases here they have mentioned it's a first line, but in not in every cases you have to consider if it is a massive or submassive pulmonary embolism or patient stable or unstable. According to that only you have to select the treatment, because you can have a look in our theory class, because I have explained everything here like an unstable case. Here, what we should start low molecular weight heparin. Okay. Today, I'm not going to explain like every emergency question because it's not topic related, right? So please go and check our previous sessions for that. Okay, I will share the links for my cardiovascular sessions and other neurology sessions, because some cardiology and neurology sessions are not yet uploaded in the YouTube. Because of that, I will share it. Okay, don't worry. Yeah. When we are using increase in enoxaparin here, would provide therapeutic anticoagulation, but oral anticoagulation is preferred when available. If this is not available, we can go with this increased level of enoxaparin. I'm like reading this part. Why? Okay, in November. Yeah, this is no, this is February. 1 minute. I have not attached that question, I think. Oh no, okay, this is, yeah, in November, doctor, in November. November, okay, this is also, yeah, from November. Post-surgery version enoxaparin 40 milligram had small bilateral pleural embolisms. Options were increase enoxaparin 80 to 80 milligram BD, stop enoxaparin and start warfarin, stop enoxaparin, and the recaller mentioned there's a no options for DOAC. If there's a no option for DOAC in small pulmonary embolism with stable patient, what we should do next step is we can increase enoxaparin because it's also anticoagulation. We need to start with the therapeutic dosage, right? Please keep these two options in your mind because sometimes they are not giving DOAC in the options, right? Yeah. Right. I have the same thing, doctor. Same thing I have attached here. So in that case, mm-hmm, yeah. Yeah, so here same question, enoxaparin 40, and here also they have not mentioned about DOAC option. So for now we can go with enoxaparin increase level to 80, but if the DOAC present, go with that. If DOAC not present in the option, then go with this. Okay. Here, yeah, here the alternative for DOAC is not suitable or not listed in the options. Go like this. Please read each points very carefully, okay? Because I have explained some like confusing points, like because I know everyone is having the question. Like in November, we have taken it as the enoxaparin 80, and now like in other recalls files, they are taking it as DOAC. Why? Why? What is the problem? There's no problem. The thing is you have to understand when to use this enoxaparin, the increased level therapeutic dose. It's when DOAC is not available, right? Like that. Okay, so for now, I'm going to mark this one as the option because uh, we don't have DOAC in our options. Okay, the next one. Here also the February calls and here February and November. Everything is included in this file. Okay, this is my exam week file, doctor. Okay. So next one, present following motor vehicle accident, hemodynamically stable. CT abdomen shows contains splenic hematoma with active contrast extravasation management. So, what do you know about splenic injury, doctors? Splenic injury, very important. You have to understand about splenic injury. So, in February recalls also, they have given splenic injury questions. Now, tell me, what are the like in here what we can use? I know like most of here doctors are from March, sorry, not March, April and May. I'm 100% sure they have done this splenic injury questions earlier. So now tell me the answer. What are the factors that we are considering when we are assessing the splenic injury? Tell me, doctors. Okay, now tell me what is the factors that we can use in splenic injury. The hematoma, right? Hematoma, the laceration level, right? Laceration level. Then if the patient is extravasation and the leakage part, right? And if there is a flush of blood present or not, right? Like that. Let's go through this. These are the option. These are the February calls. Okay, so we'll do some questions. We start from here. We'll do some questions, then you have to answer me, then I will explain. An 18-year-old man present to the emergency department. Yes, hemodynamic stability as well. 18-year-old man presented to the emergency department with abdominal pain, and he had been playing football earlier in the day and was kicked in the left upper abdomen. He has no significant medical history and take no regular medications. On examination, his pulse rate is 90, BP 110 by 70. Respiratory rate is 24 and SpO2 98%, and he has a 1 minute, respiratory 21st PO to 98, and he has a tenderness in the left upper quadrant. No abnormality was detected by the bedside abnormal ultrasound. The CT scan is performed, which shows 4 centimeter laceration across the lower pole of the spleen, which blush adjacent to the splenic hilum. So, which one of the following is most appropriate next step in management? First, you have to answer, then I will explain. Because here, like most of the doctors are exam oriented doctors, and we have discussed this in February as well. So, tell me what is the answer, doctors? Mm-hmm. Okay, and tell me why we are going with C. Give me some clues as well. Because during the exam, there's no one here to explain, right? Just you and your computer, right? In that case, you have to think like this. Okay, great. In what else? Mm-hmm. Stable. Okay, what do you think about this? There's a spleen with a blush. What does that mean? A spleen with a blush. What does that mean? What does that mean? Mm-hmm. Yeah, there can be some active bleeding. Remember this blush? Yes, there's an active bleeding, right? Okay, we'll check the answer here. The patient is having grade 3 splenic injury as defined with laceration more than 3 cm. The observation of blush during the arterial phase of CT scan implies active bleeding with extravasation and pooling of contrast. This finding ongoing bleeding in hemodynamically stable patient and indicate for angiographic interventions. So should angiographic intervention, angiography and embolization. So embolization fail or the patient become unstable, then we have to go with surgery, may then be required. Here this is the guideline, okay? Please remember each word of this guideline. So grade 1. We have to consider it according to the hematoma and the laceration. In grade 1, what we can do, patient is subscapular injury less than 10% of the surface area. The hematoma is less than 10% of surface area, and laceration, capsular tear, capsular tear, then less than 1 centimeter parenchymal depth, less than 1 centimeter. Okay, then here laceration 1 to 3 centimeter parenchymal depth. Oh, no, sorry, I was reading this part. Sorry, mistaken, doctors. This is grade 1, capsular tear, less than 1 centimeter parenchymal depth. If it is grade 2, hematoma is subscapular, still subscapular, 10 to 15% of surface area, and laceration 1 to 3 centimeter parenchymal depth, no vessel involved. Then grade 3 hematoma is subscapular more than 50% of surface area expand in the laceration more than 3 centimeter parenchymal depth, and here vessels is included. Then in that case we can consider angioembolization, right? Then grade 4 laceration, segmental or hull involvement, and grade 5 laceration is shattered spleen. Then grade 4 we can do angioembolization. Grade 5 there's a shattered spleen. We have to do the operation, right? Because the spleen is destructed, right? Shattered spleen. And the vascular one, hilar vascular injury and devascularization, right? Yeah. Please keep these points in your mind. Then we'll do some questions. Another question. So you have to answer correctly. This one. A 18-year-old man presented to the emergency department after head-on motor vehicle crash in which he was restrained front seat passenger, and he has been 1 liter of isotonic saline by the retrieval team on the way to hospital. He complains of left upper quadrant pain and He has no significant medical history and does not take any regular medications. On examination, he appears unwell with pulse rate 112, blood pressure 98, then respiratory rate 24, SpO2 98, then temperature 36.4. And he has a tenderness in the left upper quadrant with localized rigidity. Investigation revealed hemoglobin 94, then lactate 1.8, CT scan performed. And which one of the following is appropriate next step in management? Tell me what type of skin laceration or spleen injury we can see in this picture. In here, what type of spleen? Okay, grade. How many? Like what is the grade? And what is the what you can see? What type of spleen is here? What happened to spleen
Shattered
here?
spleen.
Yes, shatter spleen, right? Yeah, that was the thing I was asking. Yeah, okay. Here, but we can do the splenectomy, right? The surgery part. Here also they have explained the same thing. Yeah, you can go through it. Okay, then there's a one exceptional point you have to remember in pediatric population. Okay, this is the yeah. You have to answer this one. A 10-year-old boy presented to the emergency department of a tertiary referral hospital with a 6-hour history of increase in upper abdominal pain. He was kicked in the abdomen during the soccer game earlier in the day, but continued playing. The pain only started at the end of the stomach when he has no significant medical history and take no regular medications. Then on examination, he appears well. Pulse rate is 90, blood pressure 110 by 70, respiratory rate 18, SpO2 98, then temperature 37.4. Abdomen is soft and not distended, but there is an area of tenderness in the left upper quadrant. An intravenous line is inserted. A saline infusion started and CT scan performed to assess the underlying injury. Which one of the following is most appropriate plan of management? What do you think? Yeah, here this case presents 10-year-old boy with grade 3 splenic injury following a blunt abdominal trauma. The CT scan shows the ruptured parenchymal hematoma and blood within the peritoneal cavity. The consistent with this diagnosis, the patient is hemodynamically stable, which is crucial factor for determining the management. Continued observation is the most appropriate management plan in this scenario. So, non operative management is a preferred approach for splenic injuries in children, especially when they are hemodynamically stable. This approach is recommended for all stable children, regardless of the injury grade. In well-equipped or urban hospital, the strategy has successful rate up to 95%. Right? Sorry, 95%. Mm-hmm. Yeah, splenic preservation. So this is for what? Always keep in mind about these splenic injuries in pediatric population, right? Hope you understand. Mm-hmm. Yes. Yeah. Right? Everything is clear for this one, right, doctors? Right? Okay, we'll go back to our question. So here what we can see. Okay, this is the option. So tell me here, doctor, what we should do. What we should do, doctors? Tell me what do you think? We need more details, I know, like.
Here the patient is stable, doctor, and only splenic hematoma was there, and there wasn't any contrast extravasation. So maybe we can go with the drainage only.
Yeah.
Because immediate splenectomy is not we shouldn't do,
Yes, it's
and
out. There's pericardial embolization. What do you
embolization
think
is
about
out.
that?
it's
Mm-hmm.
already out because it's not 3, 4 or
Yes,
uh,
yeah.
grading.
Mm-hmm.
So management would be like drainage, then
Yeah, so please look for observation, right? Yeah. Yeah, conservative. Yeah, doctor, you are correct. You are correct, right? So please always think about these uh, cases, right? Here, hemodynamically stable patient, right? And without active contrast extravasation, that means there is no active bleeding, right? So in that case, we got only these options. And so, I think fifth option can be conservative management or just observation, because in here the keyword is observation, right? Keyword is observation they are giving. Here, continued observation. So we can take it as observation, right? So I have attached it one. Now everything is clear, right? By heart, you have to remember these table and charts if there is like a injury chart, okay? Yeah, we'll move to the next question. I hope everything is clear. I have discussed. What? Why not B for hematoma? What, doctor? B? What is B? Why we should do a splenic artery embolization? Is there any active bleeding? Okay, where we are using embolization? Tell me. For what we are using embolization? Yeah, doctor, this is the exact file I used for my like exam week recall. Yeah, because we have to like this is how we should discuss, not like the long sessions, just very quickly, because those doctors all were in my previous this kind of recall class, then we could quickly go through the options, right? So now tell me why. Okay, Dr. Grace, now tell me why we are using embolization. So reason for the embolization, if there's a bleeding, right? If there's a bleeding, we have to do the embolization. And here, there's no active contrast extravasation. So why we are using embolization here? So what is the reason? Is there any reason that we can use embolization? Hey, can you see? Consider embolization subscapular here more than 50 surface area expanding, and here and the vessel involvement should be there. Like we just discussed, right? Here also in this question we discuss. Yeah, here what we can see, the spleen with blush addition to the splenic hilum. There's no blush or there's no extravation. So we are not going with that, okay? Here, ongoing bleeding. Ongoing bleeding in hemodynamically stable patient indication for angiogram intervention like angiography and embolization. So always think like what we should use embolization for active bleeding, right? To secure if there's active bleeding. So there's no active bleeding, just hematoma, right? The accumulated blood only here, right? There's no active bleeding. So we don't need to embolize the arteries, right? So better we can just observe because just there's a hematoma only. Right, yeah. Okay, next one. Next question. A postmenopausal female with fracture, denosumab, sacral T-score minus 2.5 and femoral 1.5. What to do? What to do, doctors? What to do?
L-Intronet.
Mm-hmm. Okay, we'll discuss some questions. Then you will understand. You will understand. Okay. A 65-year-old woman present to the GP clinic with a 6-month history back pain and recurrent fracture. Over the past year, she underwent menopause at age 52. She has a medical history of mild hypertension and does not take any regular medications except Ramipril. She has never smoked and does not consume alcohol excessively. On examination, she appears well with vital signs within normal limit. Physical examination revealed loss of height and kyphosis. Plain radiograph of the spine shows a healed compression fracture of the L1 vertebra with 30% of loss of height with no history of trauma. Dual energy X-ray absometry scan revealed T-score of -3.2 at the lumbar spine and -2.8 at the hip. Which one of the following is most appropriate, doctors? What do you think? Quickly answer. If you have done with October recalls, you know, right? Osteoporosis is a hot topic there, right? It's a hot topic for October. There are so many questions from like one recall has mentioned there's like nine of questions of osteoporosis, right? It's a hot topic
I think,
for
doctor,
October.
if it's less than -3, we can start with the teriparatide or
No,
the
just
robustosa.
answer. Just answer, then I will explain. I know most of doctors have that confusion. We have explained in our October class as well. Just answer, doctor, then I will explain.
I think E.
Mm-hmm. Okay. Yeah, here let's see. Here, the patient present with postmenopausal osteoporosis, right? We all know that's a postmenopausal osteoporosis. Characteristic by reduced bone density and increased fracture susceptibility following menopause. The combination of fragility fracture, physical finding of height, loss of kyphosis, and DEXA scan T-score -3.2 and -2.8 in hip and lumbar spine confirms severe osteoporosis requiring pharmacological interventions and loss of vertebral height more than 20% is consistent with osteoporotic fracture. Bisphosphonates are the first line pharmacological therapy for postmenopausal osteoporosis. They inhibit osteoclast-mediated bone resorption and improve bone mineral density and significantly reduce the fracture risk. Common options include oral alendronate and risedronate or intravenous zoledronic acid. They have an established safety profile and proven long-term efficacy in the preventing vertebral and non-vertebral fracture. So, denosumab is a RNK ligand inhibitor that effectively reduces the fracture risk. It is given subcutaneous 6 monthly. Okay, in 65-year-old patients, bisphosphonates are preferred because denosumab carries a risk of rebound, bone loss, and increased fracture risk upon discontinuation, particularly affecting the spine and long-term use beyond the 10 years arise concern about atypical femoral fractures. Like I'm just explaining each one of these. Okay. So answer is what? Answer is initiate treatment with bisphosphonate. Bisphosphonate doctors. If there is a if there's osteoporosis and you need to treat, always start with anti-resorptive therapy. Anti-resorptive therapy include what? Include bisphosphonate and this denosumab, right? So then you should know when to give bisphosphonate and denosumab, right? Here, why they are not using these denosumab, doctors? They are using only bisphosphonate, not denosumab, because bisphosphonate, denosumab both are first line treatment under anti-resorptive therapy, right? Hi, doctors. Yeah,
Yes,
here they are
doctor.
mentioning why. This is given in, and here effectively reduce risk. Okay, subcutaneous is 6 monthly, right? We are giving subcutaneous injection as 6 months. A 65-year-old patient, bisphosphonate are preferred because of denosumab carrier risk of rebound bone loss. Because of that, in elderly patient, we are not recommending these denosumab, right? Okay, so just quickly discuss about this osteoporosis. Okay, this is the October recall. We have so many things. Okay, here I'm going to explain in what is osteoporosis, right? We all know, and you should know about this T score. The current T score we are dividing these osteoporosis and osteopenia. So if the T score is -1 or higher, that is normal, right? -1 or higher mean +1 +2, +3, like that. If it is between -2 and -2.5, that means osteopenia or low bone density, right? Low bone density. If the patient is lower or uh, lower to, -2.5 or lower, we are taking under it as a osteoporosis, right? So keep these points in your mind because you have to first diagnose it. And when we are diagnosing, you have to follow this chart. You have to follow this chart. Okay, you have to follow this chart because, like in some cases, we are not directly going with the we are not directly going with this BMD. So sometimes we have to start the treatment, right? Treatment if there is some very high risk factors present, and sometimes if the patient is not having fractures but risk factors present, we have to think about doing fracs or BMD, right? BMD. So like. Please give it a read. This is also very important, right? Risk factors with no fractures, when to go with fracs and when to go with these BMD directly. These are without fractures, okay, without fractures, but risk factors present. In here, in our case, what was the fracture, doctors? In our case, patient is having hip and vertebral fracture both, right? In our stem, as I remember, doctors, yeah. In our stem, what we had. Yeah, postmenopausal female with fracture on denosumab and sacral T-score minus 2.5 and femoral 1.5, right? Our patient is having some, no, sacral, right? Sacral and, yeah, vertebral and femoral, right? Okay, just like consider that part. Okay, patient is having vertebral fracture, right? No, no, just sacral, right? Okay, we can take it under that. Right? Sacrum. Are we taking sacrum in the hip, doctors? Hip fractures?
Yes, doctor.
Yeah, right. We are taking because like everything is a hip, right? Yeah, we need sacrum as well. Okay. So in that case here, DEXA to establish the BMD recommendation, but not essential. You have to remember if the patient present with some minimal trauma fracture. I will show some question. Minimal trauma fracture in hip or vertebral or hip, okay? And the patient is this high risk factors. Sometimes we can directly start the treatment without this DEXA scan. Okay, here DEXA established, but BMD recommended, but not essential. Remember this point, okay? And if the minimal fracture present other side other than hip and vertebral, what we should do, we have to check the BMD, right? DEXA scan we have to do. Then according to DEXA scan only we are treating what we should do. If it is less than minus 1.5, we have to start the treatment because this part also they have asked in this March exam. Okay. So in that question, I'm not explaining this again. So for because of that, you have to understand, and today you have to follow all of this osteoporosis charts and everything. Okay, so T score is more than 1.5 minus 1.5, then you have to investigation for other cause. And yeah, I know like some doctors have, like the doctor previously asked about it. Here they have mentioned something. If T score is very high risk one, T score is less than or equal to minus 3 and recent fractures within 2 years, and O history of two or more fragility fractures, and O. These two should be present, and others are and O. Okay, with or without. And clinical risk factors like corticosteroid, low BMID, and recurrent falls, and O here and O fracture result. Here MOF risk more than or equal to 30%, so hip risk more than 4.5. Then you have to consider referral for the bone specialist. And under here, they have mentioned for bone anabolic agent like romosumab or teriparatide, as this may be a most appropriate treatment. But doctor, always you have to remember this teriparatide and romosumab not a first line treatment. Always these teriparatide and these romosumab, these are always the second line drugs. We never start treatment with these drugs. Okay, I will explain therapeutical and very clearly explain that one. We should never start from these drugs. We always give priority as the first line treatment for antiresorptive treatment. So antiresorptive, we have bisphosphonate and denosumab, right? Please remember everything, okay? Very clear. These are for the elderly patients. Here recommended for postmenopausal women and men age more than 50 years. So please keep those points in your mind. And there's one more thing. This part also they have asked in this March exam and October as well. If the patient is using glucocorticosteroid like equal or more than 7.5 milligrams per day, very high yield per day for at least 4 months, and prednisolone, this dose at least 4 months, the patient is high risk for osteoporosis. So that means you have to do the DEXA scan, because the problem in here, in this part, risk factors without fractures, you have to think if the patient is eligible for fracs or patient is eligible for BMD. Right? For that, you clearly have to understand each point, and you should know each point in here. Very important, doctors. Okay, very important. Then, okay, I'll go back to here. Okay, we discussed this one. And yeah, you can give it to read this one later. This is the management. Okay, choice of therapy for osteoporosis. Yeah. For treatment of the osteoporosis, the most commonly used drugs are antiresorptive drugs and oral or intravenous bisphosphonate or denosumab. The choice of antiresorptive drug guided by comorbidities and preference and adverse effect. And treatment of premenopausal women and young patient younger than 50 usually requires specialist input, and oral bisphosphonate often favored. Use teriparatide or romosumab is limited by strict pharmaceutical benefit scheme finding criteria, and usually they are reserved as a second line treatment for patients who are experiencing fractures while on antiresorptive therapy, right? Patient is in antiresorptive therapy, either bisphosphonate or this denosumab, and patient is still having these minus J score and fractures, everything, then we can use teriparatide or romosumab as a second line treatment. Please keep those in your mind. The other treatment, if the postmenopausal patient present, we can introduce them to the hormonal therapy as a help for the osteoporosis as well, like that. Okay. So yeah, okay, give me some contraindications that we can't use bisphosphonate. Bisphosphonate.
So, doctor, I didn't understand the point, like when we should start the teriparatide or the romosozumab. Like, if even if the T score is less than -3, then we have to start with the bisphosphonates. Then again, we can start with the teriparatide or not, like this. I
No,
didn't
doctor,
understand actually.
here,
Sorry.
who experience fractures while on antiresorptive therapy. Here, on antiresorptive therapy, patient already on this one of antiresorptive therapy, and patient still having these features like fractures, and then after measuring the T score is -3, but they should be started with antiresorptive. First thing, antiresorptive, even though any minus fracture, we have to start with antiresorptive therapy. If the patient non-resorptive therapy is still presenting with the fractures, then we have to think about second line drug, right? Because first line is not working, right? Then because of that, we can think about the teriparatide and remosumab and everything. These two drugs should be under specialist recommendation, and they are not the first line treatment. Okay, doctor, there's 9 questions in e-medicine, so go and do those 9 questions, then you will understand, okay? After the session. Then you
Yes,
will
doctor. Thank
understand,
you.
okay? Yeah. So please, we never start from teriparatide or romosumab. That's the point you should remember. Yeah. If the patient is presenting with GI motility disorders, right? Peptic ulcer, GERD, like those things like GI motility, dysmotility disorders, we are not using, we are not using this sorry, bisphosphonate drugs. In that case, what are the drug of choice we can use? What is the drug of choice we can use, doctors? In that case, it's yeah, denosumab, right? Yeah, denosumab, right? Yeah. So yeah, here also they have explained it clearly. I'm not gonna read everything because I have attached it. You can give it a read, okay? And they have given some restriction part because they are not usually asking from these romosumab and teriparatide, but we don't know, right? Yeah, it's depend on the situations. I'll show some questions. I think, yeah, this one. Yeah. 60-year-old woman present to the GP clinic for review of her bone mineral density result. She has no significant symptoms and no history of fractures. She has a medical history of rheumatoid arthritis, treated with methotrexate, folic acid, and prednisolone 20 milligram daily for past 18 months. She takes vitamins D and calcium supplement. She reached menopause at 51 and did not undergo hormonal replacement therapy. She drinks one stand of alcohol drink most night and she smoked 10 cigarettes daily. Examination appears well with vital signs within normal limit. BMI 90. DEXA minus 2.8 and Z-score minus 3. Which one of the following most appropriate pharmacological management? Now tell me the answer. And tell me why this patient is having tell me why this patient is having osteoporosis. What is the reason behind it? Quickly answer, doctor. Steroid, how long? Tell me the criteria. What is the dose and how long you should take to think about steroid-induced osteoporosis? Steroid more than 4 months. Okay. Tell me the dose as well. Dose, what is the dose? Yeah, 7.5 or yeah, 7.5 milligram prednisolone or more, right? And the dose can be changed. Usually they are given like prednisolone because they are mentioning there. But like when we consider other drugs, the drug should be changed, okay? Yeah, remember. Yeah, here bisphosphonate therapy is the most appropriate first-line treatment for glucocorticoid osteoporosis. These medications can be administered orally or intravenously, have proven efficacy in the fractures prevention in both primary and secondary osteoporosis, right? Yes. Okay, we'll do some questions. 79-year-old woman admitted under the uh, Orthopaediatric team following a fracture of the right neck of femur 3 days ago. She was about to shower when she slipped on her bathroom mat and fell on her right hip. She underwent a total hip arthroplasty 2 days ago and currently recovered well from surgery. History include diabetic mellitus type 2, which is managed by the metformin, and her HbA1c level 8.1, calcium and vitamin D performed yesterday and all came back negative, so normal. Which one of the following is most appropriate next step in management? So now tell me the option. What do you think? Quickly answer, doctors. And what other doctors quickly answer? Okay, we just only got two options, two answers from two doctors only. Quickly answer, doctors. You have to actively participate, otherwise you will never remember each of point, right? You have to actively participate, doctors. Mm-hmm. And about other doctors? What about Dr. Rakib? Mm-hmm. I am sure, doctor. He's 79. Mm. Okay, here. A diagnosis of osteoporosis can be made through clinical history. A minimal trauma fracture at a site including a hip, distal radius, and thoracolumbar spine. A fracture neck of femur warranted treatment to prevent further fracture and bone loss, especially considering the associated morbidity and mortality. The treatment option include denosumab, which is an antiresorptive medication. So antiresorptive medications are currently considered first line management of established osteoporosis, and these are usually given post-surgery once the patient has been stabilized. If the medication was not given during the hospital admission, it's important for them for the team to follow up with the patients, GP, and ensure the patients have received the medications. Denosumab or bisphosphonate can be given as a first-line treatment for osteoporosis. Prior to commencing these therapies, patients should be vitamin D replete more than 50 and normocalcemic due to the high risk of hypocalcemia. Patients should also be informed of adverse outcomes of denosumab and bisphosphonate, including osteonecrosis of the jaw and typical femoral fracture. The latter of which occurs with increase in the duration of use. Denosumab is an acceptable option in elderly patient with less than 10 years of life expectancy as it used beyond in this duration. Questions answered. Now, this is readily available in the community, only requiring 6 monthly administration subcutaneously, making it preferable for the patient compared with the weekly or monthly dosing, right? So did you understand like what is happening here? The patient is 39. Sorry, it's not 39, 79, right? Patient is like very old, right? Very old patient, and like they are preferring here. Anyway, the first line treatment you all know always antiresorptive for the osteoporosis. First line treatment. In there, they have denosumab and bisphosphonate. Here, they are taking this denosumab as the treatment because patient is having life expectancy is very low, right? It can be 10 years, right? Because patient is in 79 years of age. In that case, they are preferring like less dosing is preferred, like less dosing is preferred by because denosumab we are giving 6 monthly subcutaneous injections, right? I think that is very convenient for those patients rather than giving these bisphosphonate, right? So each question you are learning something new. That's why I'm telling always to do the e-medicine question, right? E-medicine question because during the classes we are not able to cover all the e-medicine questions, right? Yeah. But like very important questions I have collected and I'm usually added to the file, right? So you learn so many things here and one question I need to, I think, no, not in here. Have we discussed this one? I think we haven't, right? 72 women present to the emergency department. No, right? No, we have not, I think. Have we discussed doctors? I have sometimes short-term memory loss. No, right? Okay.
No, doctor.
Yeah, I will discuss. 72-year-old woman present to the emergency department after sustaining a fracture. Uh, 1 minute to her neck of femur following a fall from standing height. A total hip replacement is performed. She is usually independent at home, mobilized with a four-wheel walker. Just give it a read, doctor. I'm just. Battery is low. I'm just putting it. Yeah. Okay, total hip replacement is performed. She's usually independent in home and mobilized with four-wheel walker. Medical history include hypercholesterolemia, epilepsy, urinary incontinence, esophageal dysmotility. Okay, this is another question, another important point. Hypertension, previous provoked above knee deep vein thrombosis 10 years ago, and excision of squamous cell carcinoma from her face. Right, so her current medications include rosuvastatin, levetiracetam, perindrofil, calcium, like those things, and the DEXA -2 on the femoral neck. Then they ask in the management. What do you think? And tell me what is the contraindication here that we can take for the why we are not using bisphosphonate? Yeah, here. Why? Here, patient is having what? You have to clearly read this. Esophageal dysmotility here. The patient sustained a fragility fracture shows has a diagnosis of osteoporosis in irrespectively of her bone mineral density. She requires antiresorptive therapy. Right? Okay, then Yeah, denosumab is the most appropriate choice of anti-disruptive therapy for the patient here presented. Denosumab is monoclonal antibody. You don't need to read that. Yeah. Can be used up to 10 years, after which point transition to alternative anti-disruptive agent should be strongly considered under specialist guidance. Risedronate is bisphosphonate. That is, risedronate is a bisphosphonate that is typically used as first-line treatment for osteoporosis. However, it can cause esophagitis and making it unsuitable for this patient with esophageal disorder, such as in this patient with esophageal dysmotility. So IV zoledronic acid would be, however, suitable option. But here we have only got risendronate and denosumab calcium, these things. So for this risendronate and denosumab, the better option is denosumab right here also. Denosumab can provide effective treatment for this osteoporosis in patient with upper GI disorder. That's a point you should take. Right? Okay, then. Yeah, usually 1 minute. And these GI dysmotility disorders are caused by usually oral bisphosphonate. Okay, oral bisphosphonate. IV we can consider. Yeah, here is risedronate can cause upper GI tract irritation, those things. With solendronic intravenous administration, not recommended in severe kidney diseases, can cause transient influence-like symptoms, can cause uveitis, right? Here, intravenous administration avoid GI adverse effect. In that case, solendronic also possible indication for esophageal dysmotility because they are not taking the orally, right? Here, this is IV solendronic, right? So keep these points as in your mind, right? If the patient presenting with GI dysmotility disorder, you have to think about denosumab, if they have given solendronic acid as well, you have to think about it because this is a IV drug, right? Not we are taking it as oral drug, right? So hope you understand everything. Those are the most important point that you need to understand in here. We'll go back to our question. Here, postmenopausal female fractured on denosumab. I don't know why they have started on denosumab. Okay, postmenopausal one, sacral T-score minus 2.5 and femoral 1.5. What to do? In this case, we can think about other drugs, right? Other type of drug. But actually, we need more details. Okay, I'll show. You need to know some important point about. Yeah, because I have not marked that question. Because you need to know some points about these two as well. Teriparatide. So when to use teriparatide? Yeah, sure, no problem, doctor. Teriparatide when to use? So we all know it's after initial therapy, right? In our case, also patient already on denosumab, right? Already on denosumab. Here, teriparatide is usually limited by strict eligibility criteria for pharmaceutical benefits of scheme, and therapy must be started by specialist, and treatment must have a T-score of -3 or less, right? This is the criteria. Patient should have -3 or less and at least 2 of minimal trauma fractures, including fractures after at least 1 year of antiresorptive therapy. These are the criteria that you need to remember about this teriparatide. And you should not use younger than 25 with known suspected Paget disease of bone, who have previously had radiotherapy or involved and with pre-exciting hypercalcemia, malignancy like that. Then when to use these romosumab. Yeah, romosumab. Here, romosumab used in here also strictly limited eligibility criteria. And yeah, started by specialists. Therapy must have T-score -3 or less. They must have experienced at least one symptomatic new fractures after 12 months of the therapy of anti-disruptive therapy. They are clearly mentioned in it, right, doctors? So don't go with these other romosumab teriparatide as a first line. And in our question, doctors, yeah. In our question, like a patient is already on antidepressive therapy, but we can't go with teriparatide or romosozumab. Why? Because the T score is not less than -3, right? In that case, I think we need more details in doctor here. Like at least when like some, it can be something related to HRT, right? Like other, as example, patient is having this and patient on denosumab. We don't like other factors like patient can have some hot flushes and like sometimes they can give like this patient is controlled on denosumab and like other features like hot flushes and those features present. In that case, we can think about this HRT, right? But in here, like, I don't know, like, we need more details, doctor. Because of that, I'm not marking anything because we don't know the calcium, we don't know the vitamin D level, right? We don't know the vitamin D level, like, it's depend on the situation. So, but you all know, like, how these can present. Yeah, like menopausal hormonal therapy also can improve bone density, but it is primarily indicated for vasomotor menopausal symptoms like those hot flashes. Okay, I'm not marking anything here because you know the scenarios. Mm-hmm. Yeah, doctor. Usually, yeah, that's also a good point. Yeah, because of that, we don't know we don't have proper details, right? Yeah. Because of that, I think better we should not mark anything, but you know who they can ask, right? We have just discussed every possible case that they can ask from these osteoporosis, right? Yeah, osteoporosis has done and dusted, right? But in fracture is 1 year. No, doctor. We have to think about other treatment. Okay, other treatment because like they already have the treatment and patient is not improving, then we have to think about something else, right? Yeah, because there's no option, no questions in e-medicine like the like indications for teriparatide everything, but only we can use the therapeutic guideline indications, so follow those things, right? I'm not marking anything here, doctor, because we need to look towards into the stem very clearly. This is not a very clear stem, right? We'll move to next question. Yeah, the osteoporosis is a very good, not good, one of most confusing topic. But don't worry, we have just discussed everything. Please, after the session, do all the osteoporosis questions. This topic can be repeated in April as well because they have given it October. And one more thing I have noticed in this like 2026 exams, like for in February exam, they have given most of like 60 to 70% from the November recalls, right? November recalls. But in March, they have given most of question not from 2026 February. They have given most of questions from 2025 October. In like if April, there can be a relationship. Not 100% sure. There can be relationship. They can get most question from the 2025 September as well, but not sure. But please make sure you go through everything before your exam in September file. Okay. We have already covered September file. If you want to go through this September file, you can ask me because there can be some connection while considering back. Okay, there's some point I have just, yeah, notice. 1 minute. Okay, doctor, 1 minute. One doctor also has just sent. Yeah. Some doctors just want to join the live session and they are quickly asking me to like how I join. I just send the group link, then they will join it. Okay, sorry for the delay. So let's discuss next question. Okay, pregnant female visit you at 41 week, then no uterine contractions, rest everything normal. Modified Bishop score less than 6, next step, prostaglandin gel, amniotomy, sweep in oxytocin. What do you think, doctors? What do you think? What do you think, doctors? Please answer. This is September recall here, and you have to tell me why you are taking this answer. Okay, why? Why prostaglandin, doctors? You have to give me the exam. Why you are taking prostaglandin? Why? What is the indication here, doctors? Cervical ripening, right? Here, Bishop score is less than 6, right? Bishop score is less than 6. So we can give what? We can give prostaglandin. Okay, then I will explain. Just I am marking the answer, then it will easy. I can quickly share the file. Okay, this is exact September question. A woman 41-week gestation has no contractions. Modified Bishop score is less than 6. What is next step? Okay, what is next step? So here, okay, I'm just explaining here. She's 41 week pregnant, induction of labor indicated, right? Because she's almost late for the delivery, right? 41-week pregnant, right? Then modified Bishop score is less than 6. That means cervix is not favorable, right? Cervix is not favorable. So with unfavorable cervix, we need to do the cervical ripening, right? Okay. Then tell me, what is the Bishop score? What we can see in this Bishop score, doctors? What is in the chat? Yeah, Bishop score, we have cervical dilatation, we have cervical length, we have cervical consistency, cervical position, station, and we are making a total score at the end, right? Like considering everything. Then you have to understand about the this Bishop score. If it is less than 6, we are taking it as cervix is unfavorable. It is more than 6, cervix is favorable, right? Cervix is favorable. So keep this point in your mind. Then, so tell me, what are the indications for cervical ripening? So first of all, cervical ripening is indicated when the labor need to be induced, but the cervix is unfavorable. This is the case that we are using this cervical ripening. We need induction of labor, but cervix is unfavorable. Then we have to do something with cervix first, then we can induce the labor, right? So main indication, bishop score less than 6 in a woman who require induction of labor. So what are the common scenario that we need induction of labor? Post-term pregnancy more than or equal to 41 weeks, pre-labor rupture of membrane at the term with unfavorable cervix, hypertensive disorders of pregnancy, gestational diabetes, hypertension, preeclampsia, diabetes in pregnancy, intrauterine growth restriction when delivery is indicated, and cholestasis of pregnancy, right? So these are the some indications, and here other maternal fatal indications like that. And cervical ripening is done before induction, not during active labor. Ripening improves the success of induction and reduce the failed induction. So cervix is unfavorable. Sorry, cervix is favorable, ripening is not needed, right? We all know that. And so pharmacological methods are the first line for the unfavorable cervix. So we have prostaglandin, the most commonly used one. Gel vaginal pessary, soften the cervix and cause mild contractions. We can use misoprostol, oral vaginal stronger used carefully. Side effect, uterine hyperstimulation and fetal distress can be seen. So we have other things, some mechanical methods like balloon catheter, like that, but we are giving priority to these pharmacological methods, right? Hope you understand everything about this cervical ripening. These are the everything that you need to know about this cervical ripening. If you understand, just tell me, like everything is clear for now, right? Okay. Yes, good. Okay, then we'll discuss Next question. A child with autistic feature asking for risk factors, advanced paternal age, male sex, sibling with ASD vaccine. So, what do you think, doctors? What do you think? What do you think in this question? What do you think, doctors? Like, type your answer. Just give me 1 minute and I'll come back 1 minute. What is the answer, doctors? Tell me. Mm-hmm. Okay, here. Mm-hmm. Mm-hmm. Yeah. There can be a genetic predisposition as well, right? Okay, like sometimes associated with fragile X syndrome, right? Do you remember those things? Okay, but here you have to remember the siblings with ASD are the like most highest risk factor. I'll explain here. Okay, so here we'll do some questions. Yeah, no, this question is not very related. Okay, here this is from the internet. Okay, the sibling connection. So what are the odds? So okay, here for younger siblings of the children with autism, the recurrence rate is estimated to be between 10 to 20%. This means that if you have a child with autism, your next child has a 1 in 5 to 1 in 10 chances of also being on the spectrum. Compares this to the general population risk about 1 in 54. And you can see why parents might be concerned. But there is where it getting interesting. The risk is in the same for all siblings. Full siblings share more genetic materials than half siblings, which affect the likelihood of autism recurrence. So studies have shows that the risk for half siblings is lower than for full siblings, but still higher than the general population risk, right? And two studies have been particularly illuminating the understand the genetic factors of autism. Identical twins who share 100% of their DNA have much higher concordance rates autism than fraternal twins who shared about 50%, right? Yeah, so these are the like actually the genetic risk also present, but here the most high risk one is sibling with most highest one actually twin pregnancy, like twins. Twins are the most highest one. Like then we have the siblings with ASD, right? So this is the answer, doctors. Like everything like advanced paternal ages and everything go under this siblings with ASD. This is the most important one. Okay, I think I have attached the yeah, and here here the TG, autism spectrum disorders is likely to have multiple causes. Twin studies strongly support genetic factors as a cause and identify genetic conditions like Fragile X syndrome, tuberous sclerosis associated with 10 to 30% of causes of autism spectrum disorders. There's no evidence support to theories that immunization or parenting style can autism spectrum disorder. Specific evidence that autism spectrum disorder is caused by environmental factors like pollution is limited. Around 1% of population has autism spectrum disorder, with estimated ranging from 70 to 1 in 150. So estimated prevalence of spectrum, autism spectrum is compliant by the under recognition and under diagnosis in adults. More children with autism present in present into services. This may reflect an increased incident, but more likely to improve the case finding. and it's more common in males, 3 to 1 ratio, but increase in recognition in females and present differently. So this is from like an article, doctor. Article actually they mention this sibling factor is higher than everything, right? So please keep in mind this is another question, not very related, but they have mentioned something about the gold standard one. So we'll see 28-year-old man presented to the GP clinic with concern about his social interactions and communication difficulties. He reported long-standing challenges in maintaining friendships, understanding social cues, then adapting to the changes in routinely. He has no significant medical history and take no regular medication. So, on examination, he appears well with vital signs within normal limits, and he maintained minimal eye contact during the consultation and speak in monotonous voice. He also mentioned occasional episodes of zoning out and that his father's brother has intellectual disability. The recent blood test shows the slightly elevated TSH level. Which one of the following most appropriate next step in identify patients' likely diagnosis? So we have something autism diagnostic observational schedule ADOS2 assessment. So that is the gold standard one to assess autism. Here, the patient present with features suggestive autism spectrum disorder, including long-standing social communication difficulties, challenges with social cues, then restricted behavior. The most appropriate next step is referral for ADOS2. Please remember, because next time they can ask from that one as well. That's why I have added. Otherwise, I'm not adding this part. Okay. Yeah. Then what we can see in here, ADOS2 is the gold standard observation assessment tool for diagnosing ASD in adults and involving semi-structured assessment to communication, social interaction, and restricted repetitive behavior, part of the comprehensive multidisciplinary evaluation. Genetic. Let's see why not genetic. Genetic testing for Fragile X syndrome is not routinely recommended for diagnosing ASD in adults unless there are specific indications, including characteristic features like Fragile X syndrome followed X-linked inheritance, meaning the gene is located on the X chromosome. Since males inherited their H chromosome from their mother and Y chromosome from their father. Father to son transmission X-linked condition is impossible, right? Yeah, so remember these points as well, and please in your mind remember about the siblings factor is the highest factor. Okay, like everything is this is the most highest risk factor, not these fragile X syndrome or other things. This is the highest risk factor. Especially remember the twin pregnancies, right? Hope you understand it, right? Because in therapeutic guide, I don't know anything, they have not mentioned like very clearly about this thing, but we have some researchers in the internet, then we can get an idea, right? Everything is clear. Please remember this one. Okay.
Yes, doctor.
Yeah. Okay, let's move. Okay, next one, and same question ask for the management. So you all know what is the management for this autism babies or autism people. Is there any cure for the autism? Tell me, doctors. Mm. Yes, there's no cure, right? No cure. Yeah, there's just not only CBT. We have to. It's a multidisciplinary approach, right? Multidisciplinary approach for these autism children, right? They need psychological intervention like CBT, right? Interpersonal interpersonal interventions. Then patient need speech pathologist, right? He needs so many so multidisciplinary actual, right, management. So now tell me, what are the features of autism child? Tell me the features of autism child in the chat. Type quickly what you can see in these autism children. No, there can be eye contact as well, doctor. The eye contact is we are not considering like no eye contact support the diagnosis, but no eye contact is like we can't take it like in every cases. Some cases in the autism children they have a good eye contact, right? Usually, yeah, usually, doctor, in the MC exam recently they are giving to confuse us with the good eye contact, right? So eye contact we are not we are considering it, but not very associated with autism. Okay, because most of the cases the children is having good eye contact. Okay, keep remember in these things. Okay, communication problem, repetitive behaviors. Yeah, right? You can see social isolation, preferred only one friend, difficulty with peer interactions, tantrums and behavioral rigidity. And do you remember like AMC's favorite question, dolls arranged in parallel, right? Dolls arranged in parallel in here. This is March recall 2025. Okay. Yeah, only questions with good eye contact. Yeah, Doctor 2025. In the exam, they have given all the questions with good eye contact to confuse us. Okay, that's why. So, eye contact, like you can remember it, but not the very specific symptoms for that. Okay, this is a question in March. Okay, parent concern about the 8 years child 2025 March. Okay, otherwise, you will be confused because we have complete that file as well with our March doctors. The child is isolated, does not prefer to play with his peers, just playing with one friend, difficult to control. Control him in school, tantrums, speech, and eye contact is normal. Here, eye contact is normal. This is recall 2025 March, but his room, all doors are arranged in parallel, making sudden screaming occasionally at different times. What is the diagnosis? ADHD, autism, Tourette, OCD, like that. So here, what we can see, social isolation, preferred only one friend, difficulty with peer interactions, tantrums and behavioral rigidity, doors arranged in parallel. So occasional sudden screaming, normal speech and normal eye contact. The most important feature here is restricted and repetitive behavior. Arranging doors in parallel suggests need for sameness and repetitive pattern, right? And October, they have asked features that help to confirm diagnosis of autism. So because of that, you need to understand these features. And they have given some red flags to identify these children in their more younger ages and in more old ages. So what are those? Does not bubble, point, or make meaningful gestures by age of 8, does not respond to their name by age of 1, avoid eye contact, has delayed speech and language skills, play lacks the variety of make believe that is appropriate to their developmental level, flap hands, rock body, or spins in circles, want to be alone, right? Want to be alone, then repeat words or phrases over and over, echolalia, right? Has obsessive interest and give unrelated answers to the question and has troubles understanding people's feeling or talking about their own feelings, right? So please keep these points in your mind, okay? And I know here they have mentioned though avoid eye contact, but please don't depend on this avoid eye contact part, okay? Yeah, in emergency also you can see in autism cases, some cases they are not they are giving like good eye contact, okay? Yeah. Then the everything, the diagnosis, then the management. Here, these are the doctors that we can use. General practitioner, development pediatrician, speech and language therapist, occupational therapist, neurologist, psychotherapist, social workers. So many people have to join to treat this autism, right? So hope you understand everything. Yeah, the management and everything. Yeah, here no cure management is multidisciplinary and early intervention focus. Okay, next one. Primary. Okay, tell me the answer. Primary 41-week labor, cervix 4 centimeters, slight meconium fluid, what to do? Review in 2 hours, continuous CTG. What do you think? Quickly answers, doctors. What do you think? It's also a recall. Yes. This is February. Yeah, February recall, doctor. February recall. That's why I told you in day one, like we felt like many February recalls, but from an October recalls as well. But most of them were February. But you know, the next thing happened. They are in day 4. They have given like so many October confused questions. Mm-hmm. Yeah, here. Why, doctor? Why we should continue CTG? Here, see, like in this case, okay, this is the February question we do. Term pregnancy, regular contractions, meconium stain liquor, CTG, BHB 110, then BV8, and no declaration, acceleration present, cervical dilation 3 centimeter. What is next? In CTG, baseline heart rate 110, it's in within normal range, right? 110 to 160. Baseline variability 8 beats per minute, then normal because it's 6 to 25. Acceleration present, that means reassuring, right? Acceleration is not a problem. 1 minute. Then what else we have? We have no declaration, that means reassuring, right? If declaration present, there is a problem, but here there's no declaration, right? Cervix 3 centimeter later labor. So here this is from Western Australia. Okay, so meconium stain amniotic fluid. So management here, first and second stage of labor, continuous electronic fetal heart rate monitoring is required. Why? Because there can be some sudden complications and sudden declarations can appear, so because of that we have to continuous CTG, right? Why? Because we need to monitor this patient, right, doctors? Because we don't know, like there can be some complications, because anyways the meconium present is a little bit higher riskier, right? Higher riskier, so because of that we have to continue CTG, right? We have to continue CTG. Okay, I have attached some questions. You can give it a read this question. I'll do this question. Okay. Okay, I'll do this question. You can read this question at the home, because it's not like very important, not like can be important. You can gather some points. We'll do this question. 20-80-year-old woman present to the labor ward, 40-week gestation. She reports reduced fetal movements over past 24 hours. She has no significant medical history and take no regular medications. On examination, she appears well. Her pulse rate is 88, blood pressure 125 by 80. Respiratory rate is 16, SpO2 98 and 98 to normal layer. Temperature 36.7. The cervix is 4 centimeter dilated. Artificial rupture of membrane reveal thick meconium stain liquor. CTG comments. CTG trace shows baseline fetal heart rate from 155 with reduced variability. There are repetitive declarations that start mid each contraction, continuous for 30 seconds after each contraction has stopped. The fetal heart rate drops to 100 with each declaration with slow recovery. The declaration occurs with every contraction. Which one of the following most appropriate next step in management? So, what do you think? Think and answer. You don't need other options. Think and answer what we should do. What do you think? Minute. Okay, I'm reading the options. Yeah, we asked it. Mhm. Actually, you don't need options, right? Yeah, emergency C-section, right? Yeah. Yet prepare for emergency C-section. I want you to understand when we should go with the C-section and when we use normal delivery with continuous CTG, right? Now you know what are the indications for immediate C-section and continuous CTG part, right? Yeah. Yes, CTG showed late declaration and fetal heart rate drops, right? Meconium stain, liquor, like so many things present in here. So not appropriate continuous CTG. We did, but immediate C-section, right, doctors? Yeah. Okay. Next question. Yeah, I think. Okay, next question. Vulva itchy, not responding to course of itraconazole. Physical examination appears vulva white and fusions. So, what is the treatment, doctor? So, first of all, diagnose this, then treatment. Tell me the diagnosis, then treatment. Quickly. Quickly, you have to answer, doctors. Actively participate. Tell me, doctors. Yes. Okay. So, what are the features of lichen sclerosis? Lichen sclerosis. What are the features of lichen sclerosis?
Lichen sclerosis will be like some architectural changes and severe
Mhm.
itchy,
Okay.
then white,
What is the,
white
okay,
patches in
appearance?
between.
What is the appearance, doctors?
Appearance, mm, I forgot, doctor. Oh, figure of eight. Yeah, figure of eight will be
Mhm.
the main appearance in case of the lichen sclerosis.
Okay, let's discuss. Mhm. Okay, let's discuss about this. And tell me, what is the type of a steroid, topical steroid that we are using? What is the type of like choice of steroid? Choice of steroid.
Betamethasone propionate, like topical.
Mm-hmm. Okay. 1 minute. Okay, yeah. Like, don't you remember about other drug? I'm just asking, like, very potent drug. What is the like very strong one we are using in here? Dr. Abab, Dr. Grace, Doctor. Have you forget clobetasol? That is a choice of drug, yeah. Why you are not answering me? Because like new doctors is fine, but the doctors who are yeah who are with me for like we have discussed like 5 months of records together, right? And yeah, we have discussed so many things. And you in your mind, like when I asked you lichen sclerosis, you have in your mind there should be this picture. There should be this picture with all the features and treatment always should be clobetasol first line. Clobetasol, right? Yeah, you have forget it, right? Okay. Please revise it again, okay? So lichen sclerosis, what we can see, doctors. So typical age is postmenopausal, right? So symptoms severe itching, burning, dyspareunia, right? Then what we can see thin white parchment paper like uh, appearance, right? Then we have a loss of labia minora and labial fusions, narrowed introitus, clitoral hood buried. So these kind of things we can see here. Narrowed of introitus, fusion of labia minor, right? Clitoris, phimosis, bleeding under skin, mild hyperkeratosis, like this. And you can see this is like a parchment paper, shiny paper like this. And here, like remember this picture. And here, important risks are the increase of vulva cancer. This patient increased risk of vulva cancer. If you see something like this kind of presentation, what we should do initially, you have to do the biopsy, doctor. Biopsy to exclude the cancers, right? Please keep this point in your mind. And remember about the treatment, high potency topical steroid, right? Clobetasol are the first line treatment. First line treatment. Okay, this is a good question because you need to understand something. Okay, from this one, I'll explain. So, 68-year-old woman presented to the GP clinic with 1 year history of vulvage. Soreness, she has tried over the counter antifungal cream without improvement. She has no significant medical history and take no regular medication. She is postmenopausal and had 3 normal cervical screening tests most recently 2 years ago. Examination appear well with there is a well demarcated erythematous slightly raised plaque on the right labium majus with scattered whited area. The lesion is not indurated and there's no lymphoadenopathy. Which one of the following is most appropriate next step for this patient? Quickly answer. I'm not giving too much answers. Quickly. Why? Here, doctors, we have to refer this patient for biopsy. Why, doctors? Here, refer for biopsy is essential as a histopathological identification of Paget cells within the epidermis and assessment of invasive diseases so associated with other adenocarcinoma, right? So please keep these things in your mind if you are suspecting Lichen sclerosis and they are asking what is first line investigation, then you have to think about biopsy, why you have to exclude other possible causes, right? Yeah, like that. And you can give it a read. This is a cancer case, okay? Paget extrapapillary, sorry, extramammillary Paget disease of the vulva. So you can give it a read this later, okay? Yeah, like presentation, they can ask something like sometimes from this topic as well. So because of that, I have added. Okay, this is the next question. 58-year-old woman present to the GP clinic with 6 months history of vulvage and soreness. She reports the skin appears pale, thick, and she has no significant medical history, no medications, and not used over-the-counter treatment. Her cervical screening is up to date. Her mother also has similar symptoms, and she has had it treated previously 15 years. On her last menopausal was 4 years prior. On examination, she appears well with vital signs within normal limits. Gentle examination revealed wide atrophic patches on vulva with some architectural distortion. There's no bleeding ulceration, no obvious mass. Which one of the following most appropriate first line treatment? They're asking treatment here. So, what is the first line treatment? Here, topical clobetasol propionate. Please keep this point in your mind, okay? Yeah, clobetasol always. When I ask lichen sclerosis in your mind, there should be a clobetasol, right? Yeah. Here is a potential topical corticosteroid. This is a gold standard first line treatment. Gold standard first line treatment, right? It should be applied once for 4 to 8 weeks, then gradually reduce the maintenance regime. This treatment being show improved symptoms 95% of patients and signs 75% of patients, right? So give it a read of other things they have mentioned in here as well. So because of that, I have like here mark look for clobetasol. Usually, like if they want the treatment, they are asking about this clobetasol. Okay, this is a gold standard treatment. Okay, how atopic vaginitis present for your another knowledge. Typical age is postmenopausal, so dryness, mild itchiness, dyspareunia, urinary symptoms can be present, right? Pale thin mucosa, loss of rugae, no scar infusions, right? Treatment topical vaginal estrogen. This is a typical presentation. And vulvovaginal candidiasis can be present like this. Like cottage cheese appearance, and other than that, sometimes vulvovaginal candidiasis can present like red brick vagina as well. Remember these points, okay? I will explain when we, yeah, it can be alternative, but always look for clobetasol. If clobetasol is not there, you can go with other options, right? But always firstly look for clobetasol, right? Yeah. Here we will explain. I will explain if we get a vulvovaginal candidiasis question. But here just for your, yeah, for your knowledge. Okay. Next one. A 4-year-old knee pain, difficulty to walk, X-ray, left slip epiphysis, appropriate management. Tell me, what is the appropriate management, doctors? Quickly answer. Quickly answers, doctors. Mm-hmm. Okay. So now tell me about this one. So, what is slipped femoral epiphysis? So, what is slipped femoral epiphysis? What is happening there? What is happening there, doctors?
I think the femoral head displaces posteriorly.
Mm-hmm. Yes. So why this is happening? It's a displacement of femoral head, right? Due to growth plate weakness, right? Due to growth plate weakness. So just to keep these points in your mind, okay? Yeah. Why? Due to growth plate weakness. Now tell me, what are the key factors that you should remember for this disease? This is like what is the age and like
It will be
who
like from 10 to 13, an
are.
overweight patient, a obese child,
Obese, usually male predominance can be
male
seen in here,
predominance.
right? Yeah. In e-medicine, they have mentioned like the time period is the age period is 10 to 15, right? But in RCH, they have mentioned like 12 something. But remember the range is 10 to 15, okay? 10 to 15. Then now tell me, what are the types of these slipped femoral cap, sorry, this slipped femoral epiphysis? What are the two types of this disease? It's a very long name, so I don't like to read it. Okay, now tell me, what are the main types? What are the main two types? Tell me. We have doctors, Dr. Abab, answer me. Yes, stable and unstable, right, doctors? Yeah, here. We have mainly stable and unstable. A stable means patient is able to weight bear on the affected leg. Unstable means the patient is unable to weight bear on the affected leg, even with crutches, right? Even with crutches. So yeah, current duration we have acute, chronic, acute on chronic. So like the important one is this stable and unstable, right? Here, how common they are in most common in boys than girls with mean age. Here, I told you mean age 13.5 in boys and 12 in girls, right? But remember the range, okay? Then, yeah, what are the clinical features we can see in these patients? Clinical features, just quickly tell me clinical features. Quickly.
Like thigh pain, thigh or knee pain,
Mm-hmm.
then patient will feel complain on the pain in the groin area as well.
Mm-hmm. Yeah, we can see what? We can see groin, thigh and knee pain, right? Groin, thigh or knee pain, we can see. Then there's a limp, right? Patient is on antalgic gait, right? Antalgic gait. Then these legs are usually rotate at which side at the wrist? The legs rotate at which side? Not side or how like rotated. Sorry, legs are present at the wrist.
Internal rotation.
No, legs are externally rotated, doctors. External rotated. Okay. Please keep these points in your mind. I'll show. Okay. External rotated. This patient has have the loss of internal rotation. Patient is having loss of these are key points, okay, because these points are given in the stem. Loss of internal rotation. Then there is a one sign we can see in here, Draymond sign. So what is Draymond sign, doctors? Have you not watched the pediatric orthopedics session? I have explained Perthes, I have explained these transient synovitis, these slipped femoral capitis, like everything I have explained and every point I have explained. If you have not done it, please go and check that one as well, okay? Because Perthes, transient synovitis, all three you have to differentiate, right? Yeah. Okay, patient needs. Do you know about German sign? German sign that mean if we flex the hip, automatically these hips rotate externally, right? If we hip the flex, hip rotate externally automatically. That's we call Raymond sign. Okay. Then how we should investigate these patients? We have to done the X-ray, and I will explain X-ray from my emergency question. Then the treatment doctor, and you should know all these patients with slipped femoral capitis epiphysis. We have to refer this patient for orthopedics. All patients should refer, right? All patients should be refer. Mm-hmm. Yeah, and all patients with this needs surgical stabilization. The patient need to be kept on non-weight bearing bed or wheelchair only, no crutches, and admit for the surgical treatment. Right, and here the surgical treatment in here is the pinning and internal fixation. Pinning and internal fixation, right? Yeah. And always remember the urgent orthopedic assessment should be done, right? All patients. Okay, here we'll do this question and I will explain the X-ray from here. A 14-year-old boy brought to the clinics by his parent because he has been limping for the past 2 weeks and is complaining of pain in her left hip. There's no history of trauma or fever, and he is otherwise in good health. On examination, his blood pressure is 112 by 74, pulse 86, and temperature 37.2. His height is in 75th percentile, and his weight is in 90th percentile. There is a hip pain on palpation and limitation of hip range of motion, especially internal rotation and flexion. His blood investigation are within normal limits and AP radiograph bilaterally. Hip is followed. Here you can see both hips are given. Then which one of the following is most likely to diagnosis, and tell me what we can see in this X-ray. What we can see in this X-ray? What we can see, doctors?
We can see
Okay.
that Prethwan line is not in appropriately,
Mhm.
like
Yeah, here.
the
Okay,
femoral
this
head
is.
and the
Mhm.
trochanter is not in straight line. There
Yeah,
is
okay.
something above the line.
Yeah. Okay, before that, we'll get the information from this one. Okay. His hip pain in 14-year-old boy whose weight is 90th, obese, right? Present with X-ray findings such as one of these case suggests diagnosis of these slipped capital femoral epiphysis. In the normal AP view, the line drawn along the superior femoral neck, the Klein line, right, intersect the lateral portion of femoral head. Okay, here this is the Klein line, right? Plain rights intersect the lateral portion of the femoral head. But in this disease here, it's under the head is under this plain line, right? Head is under the plain line, right, doctors here? So you can see, and we call it Trethovan sign, right? Please keep this is in your mind, and this is a picture that you can see in here. Okay, yeah. Yeah, that's on. Mm, yeah, doctor. Okay, another one question. 13-year-old boy to the GP. Uh, like mother was with comes with mother. 3-week history of limp and increase in left knee pain. He first noticed the pain after playing soccer at school 3 weeks ago. There is no recent history of trauma. Previous episodes of joint pain. He described the pain is being associated with his left knee radiating to his left thigh and groin. The pain has progressively worsened and now find it difficult to weight bear on his left lower limb. He has no significant medical history and up-to-date immunity. On examination, he appears overweight with BMI 39. He's uncomfortable and work with antalgic gait. His left lower limb shortened and externally rotated during the flexion of the hip, Draymond sign flexion of hip, and it is external rotated, right? The Draymond side. Which one of the following is most appropriate next step in management? Quickly answer. Quickly answers, doctors.
Urgent orthopedic assessment.
Yes, urgent orthopedic assessment, right? Yes, good. Very good. Yeah, urgent orthopedic assessment, right? Yeah. So, yeah, doctor, and I have attached other questions like you can differentiate with other diseases, okay, for your referral. Okay, we'll go back to our question. So, so pinning and internal fixation, I have attached. The recall only give the option as pin, so I have attached full. What we can do is pinning and internal fixation, right? Hope you understand everything about this one. Okay, next one. A girl on risperidone, no menses for 6 months. What else she might experience? And we got only galacturia. Now tell me, girl on risperidone. Because of risperidone, how this affect? How this amenorrhea present? How this amenorrhea associated with risperidone?
Because of increased prolactin.
Okay, okay. Now tell me how prolactin affect for these amenorrhea stepwise. Tell me, doctors.
Prolactin inhibit the what is called,
GnRH.
then it
Mm-hmm.
inhibits the LH and the FSH. So
Yes, yes, yeah, yeah. You are correct, doctors. Right. So you have to think about like because you need to know the these. Yeah, some doctors have mentioned. Yeah, hyperlactemias. Yeah, yeah. So it affect what? If affect GnRH, right? So GnRH is the one that responsible for producing FSH and LH, right? They stimulate the production of FSH and LH. If the GnRH decrease because of the hyperprolactinemia, that can affect the production of LH and FS, right? FSH. So if these things are decreased, then it can affect the ovulation of the patient, right? Ovulation of the patient, right? Then estrogen also decreased and ovulation affect. Then menstrual cycle can be stopped, right? Then amenorrhea can present. How galacturia present, doctors? How galacturia present in hyperlactinemia? How? They can, what we can do prolactinemia? What is the like connection between milk production and prolactinemia? Tell me, doctors, because then you can easily understand these questions. I know everyone know like what is happening, hyperlactinemia, galacturia. I'm just asking like pathophysiology behind it. Why?
I forgot, doctor, the
Mm-hmm.
pathophysiology.
Okay, yeah. Due to prolactin stimulate the breast tissue to produce milk, right? Produce milk, milk production controlled by this prolactin, right? If the high level of prolactin present, so that means milk production can be seen even in non-pregnant patient, right? So because of that, we can see galacturia, right? So the we got only option here with amenorrhea and everything. We can the galacturia makes sense, right, doctors? Girl or risperidone, long-term antipsychotic use that can cause what? Hyperprolactinemia, right? I have explained in here. Hyperactinemia can cause infertility, sexual difficulties, and everything. The same thing that we have just discussed. So keep these points in your mind. The next one, the growth parametric of baby with IUGR, serially reducing growth parametric, especially head and chest length least, asking for the diagnosis, right? So what do you think? Quickly answer.
IUGR, torch.
Mm-hmm. Torch. What about other doctors?
I think it is the symmetrical IUGR. So torch can be one of the cause.
Mhm. Okay, yeah, this question kind of weird question. Okay, I know. Okay, we'll discuss about this IUGR. Okay, IUGR a little bit, then we'll come back to our question. Okay, yeah, doctor. Okay, now tell me what are the features of symmetrical and asymmetrical IUGR? Tell me how it presents. So, asymmetrical one usually in late pregnancy, right? Late pregnancy and symmetrical one early pregnancy we can see associated with chromosomal abnormalities, these storage infections, right? Alcohols, right, doctors? So, we can see in early pregnancy. Okay, we can see in early pregnancy, but the symmetrical one, late pregnancy, we can see asymmetrical one. The primary cause of asymmetrical IUGR is what? What doctors? We have placental insufficiency, right? Placental insufficiency. Because of that, patient can have asymmetrical IUGR. Then the most important part, this ratio and these circumferences, right? In asymmetrical IUGR, what we can see? Head circumference is normal or mildly reduced. But normal or mildly reduced, and abdominal circumference is reduced. Here it is reduced. So now tell me what is the ratio? HC and AC ratio. Head circumference and abdominal circumference ratio in here is increase. Brain spare in Y. Here because why this is increase in doctors? The ratio. Because
Because the
abdominal
head
circumference.
circumference is normal here.
And abdominal circumference is reducing, right? Because of
Yeah.
that, the upper one is going up. So, yeah, this is increasing. Then, so in symmetrical one, head circumference and abdominal circumference both are symmetrical, right? Symmetrical, both are reducing here. So, this ratio can be normal, right? Ratio can be normal. Yeah, you remember, right? I'm drawing and explaining about the head and everything. Okay. Today I have attached some pictures, so I don't need to draw anything. Yeah, in previous classes I have taken the parameters and I have explained because some doctors were mentioned like they don't understand it. So yeah, we had to do some
We missed
simple.
your classes, doctor, because I have joined today.
No, doctor, not this class, doctor. Like in previous month's class. Yeah, not
Oh,
this
previous
March
month, the
recalls. Yeah,
February
I
one. Oh,
I have done like 5 months of recalls with the other doctors. Most doctors have done the exam in March. Yeah, in November, right? Yeah. Yeah, only we have, I think, 3 or 4 doctors here. Like other all doctors are new, right? Yeah. Okay, here. Because this is very easily understand. So then amniotic fluid here, what we can see in asymmetrical IUGR amniotic fluid, we can see oligohydroamniosis like low amniotic fluid. Then in symmetrical one, this can be usually normal. And like droplet studies also can be usually normal. And here Doppler studies can be abnormal. Here in Doppler studies abnormal, right? Then growth pattern disappropriate, and here disproportionate, and here this can be symmetrical one proportionate, right? So yeah, here management surveillance, early delivery compromise, and investigate. We have to in this case investigate the cause, right? Yeah. Okay. Also the same thing I have mentioned. In symmetrical IUGR here, the asymmetrical one, we can see the large head baby, right? Large head baby in asymmetrical IUGR, right? Macrocephalic baby in asymmetrical IUGR, right? Yeah. Okay. So we'll do some questions, then you will understand like what are the things that you need to so you need to know about these IUGRs. Okay. A 28-year-old woman present to the antenatal clinic for routine follow-up at 32 weeks of gestation. This is her first pregnancy. She has no significant medical history and does not take any regular medications. She reports smoking 10 cigarettes per day throughout her pregnancy despite counseling. On examination, she appears well with vital signs within normal limits. The symphysis fundus height measures 28 centimeter. Ultrasound scan revealed following measurement by parietal diameter 79, head circumference 287, abdominal circumference 249, femur length 60. Estimate fetal weight is at 12th percentile. A scan performed 4 weeks earlier showed all parameters between 40th to 60th percentile for the gestational age with the estimated fetal weight 56 percentile. The current Doppler study of the umbilical artery show increased resistance. Which one of the following is most likely to diagnose this? What do you think? What we
I
can
think
see?
it is symmetrical.
And about other doctors?
Head circumference and abdominal circumference increased.
Okay, what about other doctors? Quickly type in the answers. Mhm. Okay. Okay, here, let's discuss. Here. This patient present with fetus consistent with asymmetrical intrauterine growth restriction. The key findings supporting the diagnosis include the symphysis fundal height measure 28 at 32-week gestation, below the expected measurement, right? The discordant fetal growth with abnormal circumference of the fifth centile, while head measurement remained 50th percentile, demonstrating head sparing. A significant drop in growth percentile compared to the scan 4 weeks earlier increased the resistance of umbilical artery. Doppler studies suggesting placental insufficiency. And the patients continued to smoking during the pregnancy, which is significant risk factors for intrauterine growth risk factors. Asymmetrical intrauterine growth restriction characteristic by disproportionate growth reduction with relative preservation of head circumference and fetal brain, but reduced abdominal circumference. This head sparing effect occurs between the fetus redistributes blood to the vital organs like the brain at the expense of other organs, which placental insufficiency develop, right? Asymmetrical intrusion growth typically result from the late gestational insults such as placental insufficiency, often associated with maternal factors including smoking, hypertension, preeclampsia, right? Like that here. The patient also, 32-week gestation.
I didn't understand, doctor, like why it's asymmetrical.
Why? What is the problem, doctor?
Uh,
Okay, here okay. HC and AC ratio, head circumference is what? 287, right?
yeah,
Then abdominal circumference
abdominal,
is 249, right?
yes,
So what is increased?
it has increased.
Yeah, okay, so increased in where?
Oh, sorry. Yeah,
Right?
in case of
There's no
asymmetry, it
problem,
increased.
right? Yeah.
Yeah, I'm
Yeah,
sorry.
so brain is
I thought
spared,
it
right?
increased in the symmetrical, that's why.
No, no, doctor, right? You
Thank
got
you,
it
doctor.
right? Yeah.
Yeah, thank you.
And yeah, here also head, you can see, right? Heads, yeah.
Yeah, but the thing is, in my head, I was thinking like the symmetrical portion was in the first and asymmetry was in the later. That's why in my head it was like in the
No, no, no,
table.
doctor.
That's
Symmetrical
why.
one is earlier pregnancy, and the asymmetrical one we can see late pregnancy.
After
Remember in
pregnancy,
the,
little
yeah,
insufficiency of the
usually,
placenta.
yeah,
Yeah,
you can remember like placenta insufficiency, those things, right? In late pregnancy with asymmetrical one. In the earlier one, symmetrical one with associated with these like torch infections, right? Chromosomal abnormalities, like that. Okay. Like you have
thank
to
you, doctor.
work hard this one. Yes. Then why not symmetrical one? Symmetrical would show the proportional reduction across all fatal measurement, including head circumference, biparietal diameter, abdominal circumference, and female. And this pattern typically results from early gestational insult, which is a chromosomal abnormality or congenital infections or early placental dysfunction affecting overall fetal development from early pregnancy. Right? Hope you understand it. And yeah. I have attached asymmetrical growth restriction describe infant with disproportionately low weight and abdominal circumference relatively to head circumference, often due to a later gestational insult such as placental insufficiency. And this is brain sparing effect in here, right? Yeah. Okay. And yeah, you have to remember this one as well because we can gather some information from here. A 8-year-old woman present to the antenatal clinic, 28-week gestation. This is her first pregnancy and she has no significant medical history and she does not take any regular medication. She is a non-smoker and work as an accountant. On examination, she appears well with vital signs within normal limits and her symphysis fundal height measures 28 and growth scan is 2 weeks ago shows estimated fetal weight on 50th centile. Which one of the following is appropriate next step to assess the fetal growth? Tell me. Tell me, doctors, what is the option? This question can ask very important question. What about other doctors? Okay, Dr. Abab and Dr. Kumari, you already know, right? You have done this question with me like 3 to 5 times, right? I think. Like, okay, what about other doctors? Very important point, doctors. This one. Okay, here. The answer
I
is
don't know,
what?
doctor.
Yeah, serial growth scan at 2 weeks interval. Please remember this one, okay? The patient present with clinicals and ultrasound findings suggesting possible fetal growth restriction. The symphysis fundal height is measured in small 4 days and estimated fetal weight is relatively low, though still with the normal ranges. The serial growth scan at 2 week intervals is the most appropriate next step. This allows for tracking of growth velocity and detecting of crossing centile line, which is more accurate for diagnosing intrauterine growth restriction than a single measurement. A decrease across the centile line suggests the true growth restriction rather than constitutional smallness. Yeah. And this is another question. Okay. So, okay. Okay, no need to read this one. Just tell me which one of the following is most accurate method of diagnosing intrauterine growth restriction. So this is another very important point. Very important, okay? Very important. That's why I have marked it as a red color. So tell me what is the most accurate parameter? Okay, let's see. Yeah, here. The serial measurements of fetal abdominal circumference is the most accurate single parameter for diagnosing IUGR. The abdominal circumference reflects liver size and subcutaneous fat deposition, making it more sensitive indicator for fetal nutrition and growth, right? The declining growth velocity on the serial measurement is more significant than a single measurement below the 10th centile, right? So these are the very important point you should remember. So let's go back to our case. Here, a growth parametric of baby with IUGR. They have already given with IUGR, right? The serial reducing growth parametrics, especially head and chest length, asking what is the cause, right? Actually, like this question is not completed, right? Because we don't know where. We don't like the not the gest we don't know gestational age, right? We don't know other parameters, right? Other parameters, especially like what the fetal abdominal circumference parameter, because it's very sensitive for IUGR, right? We need to know like what are the other parameters in the stem. Then we can think about if it is like IUGR or torch infection, normal low, small for gestational age, right? Doctors, because like this is not enough, because at least we need abdominal circumference because it's the most sensitive one. Here they have given head and chest length. Then if they have given abdominal one and the head one, then we can get an idea is it a symmetrical or asymmetrical. Then we can find out the causes, right? Yeah. Here it's not enough, so I'm not marking anything here. And other than that, I have like added some how explanation. The system says serial reduction growth parameters, which mean the baby's growth is progressively falling or follow-up scans. They indicates pathological growth restriction IUGR, because in the stem they have mentioned there's IUGR, right? They already know IUGR, but I think they want to know like which type of IUGR and cause. Like as example, if it is a asymmetrical one, you all know like placenta insufficiency. If it is a earlier one, there can be torch infection, chromosomal abnormalities like that, right? We don't know. We need more information. So HGA, how to present? How it present, babies are small but grow along in the same percentile. SGA babies are small but grow along same percentile. There's no progressive drop. And the torch cause symmetrical small fetus from early pregnancy and usually has other abnormalities like symmetrical one, right? But it's fine, you know everything about this IUGR. Now you can answer anything, right? Hope you understand everything about these topics, right? So we have discussed here. Yeah. And like we have few more pages. And this is this is file one, okay? And we have another file as well for day one. So like now we have done like 4 hours of classes, right? We started at 1.
Yes, doctor.
Yeah, so no 3 hours, right? No,
It has
4
already
hours.
passed 4 hours.
4 hours, right? 4 hours, yeah. So I'm gonna stop the session for now, doctors. Yeah. Yeah, and we can meet tomorrow. prepared because actually I am having some ALS in this weekend. I have to do some MCQs and I have to go through some PDFs as well because I was supposed to start at this classes on next Monday. That because of the April doctors, they have requested me to start it earlier. So because of that, I started today and tomorrow and day after tomorrow because Thursday I have my ALS. So I need to prepare. Otherwise, like in the most of classes, February also we did like 4.5 or 5 hours. Yeah. So yeah, we'll meet on tomorrow, okay? Because I have a like huge MCQ set before my today is the last day and I have to do it quickly. Yeah. So thank you so much, doctors. We will meet tomorrow at the same time. How is the session, new doctors? Yeah, after the
It
session
was
today, I can
perfect.
share.
It was perfect because we have understood many things, like not only the exam questions, only other as well. So it
Yeah.
was so good.
Yeah, thank you, doctor. Because other doctors know because Dr. Rabab and Dr. Chorikia, then Dr. Kumari, they were from the beginning, and Dr. Sandali as well. So like that's what I'm asking. Dr. Grace also joined in February, right? Yeah. So that's what I want to get your like opinion. Like this is how you should do the even exam week recalls, right? Not taking
Yes,
this
doctor.
much time, yeah, doctor, because otherwise, you can't waste it, especially this March exam week. You need to know like the concept only. Otherwise, questions are very confusing. Even that's not the same. Like very small parts has changed. Like after the exam, the doctors called me and they were like, I don't know, Dr. Sithara. They were so much twisted, and like thankfully they know the background and topic because we have discussed like this. So yeah, they have done it properly. I'm sure they will pass. So yeah, let's hope for the best.
So,
Yeah,
doctor,
yeah,
when we will get the PDF, like PDF and the video, because I didn't attend the class from the
yeah, doctor.
beginning.
Like after now, today we have marked the PDF as well. Like because it will take some times to like after the Zoom session, it will take some like 30 minutes like to convert into my laptop. Then I can upload it. But the
Yes,
file
doctor,
like I
no
can
worries.
upload
Yeah.
it quickly. Yeah, doctor.
Yes, doctor. Thank you so much.
Yeah. Yeah, doctor. PDF I will upload now. That's all we need to cover in on the topic. Yeah, thank you, doctor. Okay, Dr. Asna. I don't know Dr. Asna. It's a new doctor. Yeah. Okay, I'm gonna
Doctor,
stop the.
what is the tomorrow's time? Like it will be same as
Yeah,
today
doctor,
from
same
1?
because like usually I'm doing free theory sessions as well, but this week because of ALSA, I only can do the only one. Tomorrow I can do the session, but like in the next week I'm full booked with the my free recall sessions as well because I have to help the April doctors as well because they have given me the bunch of list of the topics that they need to cover. So, like after this session, I'm taking a 1 hour break. Then I'll start the free theory session. Then that
Yes,
is how
doctor.
it's yeah, yeah,
Much
okay,
appreciated actually. You are
yeah.
trying so hard for us. Thank you so much.
Thank you so much, doctor. So we will meet tomorrow. I'm gonna stop the sharing and everything. I will upload now, like within 10 minutes, the file. Then recording once it download it to my laptop. Then I have to upload it again. And please share your Gmail in the chat, doctor. Then I can easily add it you to my files. Okay. Thank you so much, and thank you so much for joining me. Yeah, today we have new faces, new doctors, and I really like to work with you all. Okay, thank you. Bye bye. Have a good day, doctor.